Dr. Abdelhadi, you can start.
Okay.
Good afternoon, everyone. Do you hear me?
Yes.
Yeah.
Yes,
We
please.
can.
So today, inshallah, we're gonna start with Dr. Abdelhadi Alama. He's gonna present us his presentation about CT scan and MRI utilization in cardiac surgery. Dr. Abdelhadi, do you have a consultant guest with you and during your presentation?
I couldn't arrange one.
Have you communicate with anyone to try to help you?
You mean, have I informed the coordinator?
I mean, anyone from your colleague, your chief president, the chief president of me, myself, as a moderator for the session.
No, I haven't.
No worries. So I believe, inshallah, we are gonna help each other. If you can start, go ahead, please.
Okay.
Muhammad, I'm here also, as if you need help.
Thank you, Dr. Khagir. So, Dr. Khagir, I believe he is a great help to us now today. You can ask him, and if Dr. Alama, do you wanna the others to ask at any time? Do you want to finish your presentation and receive questions and comments?
They can ask anytime. It's fine by me.
Okay, that's good.
Okay. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. I'm Abdelhadi Al-A'ma, and today I'm going to be talking about the CT and MRI in cardiac surgery. In cardiac CT, one of the major technological advances has been the incorporation of multiple elements into the CT detector system. This, you'll find it in the literature called the multi-detector CT. However, nowadays all machines are modern, so all are the same. All have the capability of the multi-detector CT, so it's just termed CT. We'll start with the coronary CT angiography. This is done usually to evaluate for the presence and the extent of coronary artery disease, especially in patients with stable angina. It can aid the diagnosis and the detection of the obstruction of the coronaries. Among the non-invasive tests, the coronary angio has the highest diagnostic accuracy for the detection of obstructive coronary artery disease, especially because of its high sensitivity and corresponding low rate of false negatives. Coronary CT angio is a test best suited to identify patients at low risk for future cardiovascular events. It also has helped with the prognosis and in the coronary atherosclerosis and the prediction of the possible risk of coronary artery disease. It not only detects the presence and the extent of stenosis, but also the coronary plaque. Overall, the presence and the extent of both aspects of coronary artery disease are strong predictors for future major adverse cardiovascular events. For example, the absence of any coronary artery disease gives a warranty period of up to 5 years for a very low risk of cardiovascular events, while the presence of non-obstructive and obstructive coronary artery disease carries a 3 to 6-fold increased risk for future cardiovascular events over 5 years. This is why the test findings can be used to guide management plan, either by diagnosing obstructive coronary artery disease and proceeding for revascularization procedure, or by assessing prognosis for medical therapy. In patients with intermediate or low probability of acute coronary syndrome, or patients who are hemodynamically stable with ongoing chest pain, a non-ischemic ECG, and no troponin leak, no past history of ischemic heart disease. So coronary CT angio is an effective test to exclude the diagnosis. A negative coronary CT angio is associated with at least 2-year period with very low risk of cardiovascular events in these patients. Cardiac CT always also provides the cardiac surgeon with a non-invasive method to assess graft's patency after CABG. And I'll talk about that later. While doing the coronary CT angio, the image cuts are synchronized to the ECG. A bolus dose of IV contrast is given. Nitroglycerin, usually sublingual, is given immediately prior to the examination to dilate the coronaries. Typically, a short-acting oral or IV beta blocker is administered if needed to slow the heart rate to ideally less than 70 beats per minute. You can see in the picture some of the lesions. This is the top picture. You'll see the right coronary artery. The CT compared to the angio findings, it's pretty comparable. The most common contraindications for any CT with contrast study is the severe renal insufficiency, especially in patients with estimated GFR of less than 30. If there's a history of allergy to contrast or anaphylaxis, and the fact that pre-medications may be required. Patients must also be cooperative and able to hold their breaths for 5 to 10 seconds. Cardiac tachyarrhythmias and excessive motion from the tachypnea or uncooperative patients. This also obstructs or limit the study. An inability to perform a breath hold can lead to an undiagnostic CT examination, especially with basic CT technology and not the advanced ones. The CT coronary angio detects luminal narrowing of more than 50% diameter with 95 to 99% sensitivity. However, the specificity is variable, ranging from 64 to 90%, and this is subject to image quality and underlying artifacts from patient factors. A standardized radiological reporting system for coronary CT angio or a coronary artery disease reporting and data system, CAD-RADS, has been introduced. The CAD-RADS describes the coronary CT angio findings and classifies them according to management recommendations in patients with either acute or stable chest pains. In patients presenting with stable chest pain, they can have the CAD-RADS of 0, and this will be interpreted as a documented absence of coronary artery disease. So we can just go ahead to give reassurance for them and consider another cause for chest pain. A CAD-RADS of 1 has 1 to 24% minimal stenosis or plaque with no stenosis. We consider that a minimal non-obstructive coronary artery disease. A CAD-RADS of 2 has 25 to 49% of stenosis, still a mild non-obstructive coronary artery disease. We can also consider other causes of chest pain, but we can consider preventive therapy and risk factor modifications. CAD-RADS of 3 carries a 50 to 69% of stenosis, a moderate stenosis. In these, we can consider functional assessment. And we can consider a system-guided anti-ischemic and preventive pharmacotherapy, as well as risk factor modifications. CAD rates of 4 has 70 to 99%. That is severe stenosis. That is the type A. CAD rates A, 70 to 99%. CAD rates B, more than 50% in left main or more than 70% in 3 vessels obstructive disease. That's considered severe stenosis. And treatment should be considered and in fact started. CAD rates of 5 has 100% total occlusion or CTO, coronary total occlusion. And this needs a viability assessment and then a study for the need of revascularization. CAD rates of N is a non-diagnostic study, and the obstructive coronary artery disease cannot be excluded. So he might need to go for a cath if still a high suspicion of artery disease is considered. This is the same schedule, but for the patients presenting with acute chest pain. So the CAD rates of 0 will be highly unlikely to be an acute coronary syndrome. I don't think I need to go over it again. It's pretty much the same. Fractional flow reserve. Fractional flow reserve, it's the ratio between the maximum achievable blood flow in a diseased coronary artery and the theoretical maximum flow in a normal coronary artery. And it's a calculation usually done during the cath in invasive coronary angiography. An FFR of 1.0 is widely accepted as normal. Lower than 0.75 to 0.8 is generally considered to be associated with ischemia and warrants intervention. By the CT coronary angio, FFR can be calculated, and the results of the CT FFR are reasonably in agreement to that of the cath. CT can also be used for coronary artery calcium scoring or calcium scoring. It uses a plain CT without contrast to detect calcium deposition in the coronary arteries. The presence and severity of coronary artery calcium is associated with an increased risk of cardiovascular events. So it is useful for risk stratifications and guidance of medical therapy in asymptomatic or low risk patients. The calcium scoring CT, it's an ECG triggered also. Plain CT, no contrast. It may be performed without any patient preparations. They do not need the beta blockers, nitroglycerin, or other medications. Patients just should ideally be able to follow instructions and hold their breath for 3 to 5 seconds and to lie still during the scan. Coronary artery calcium scoring is most commonly quantified using the Augustin method, which sums up the area and density of the coronary artery calcium. 0 Augustin unit means no identifiable disease. 1 to 100 is mild disease. 100 to 400 moderate disease, and more than 400 is severe disease. However, it is important to know that anatomical features such as numbers of vessels involved in the presence and the presence of proximal coronary artery disease versus distal coronary artery disease, these are not included in the scoring system, and they should be added to the Augustin score in predicting major cardiovascular events. Post-CABG CT angio can be done for graft patency evaluation directly post-op or later in follow-ups. However, surgical clips that are applied during the surgery, they can produce an artifacts which would disrupt the image and decrease the quality. So it would limit the CT evaluation of grafts. It might limit the CT evaluation of grafts. You might be able to see it. CT for reoperative surgeries. In reoperative sternotomy, re-entry is known to be challenging due to the adhesions and loss of tissue planes, and the high risk for injury to patent grafts or the aorta or the injury to the right ventricle, depending on which structure lies below the sternum. Special injury to a patent Lima graft, Lima to LAD, that is associated with a high mortality of 50%. So the cardiac CT really has helped a lot in this area. It can precisely define the relationship of these important structures to the midline and to the sternum, and the surgeon can plan his re-entry properly and take caution. For cardiac valves, there is excellent correlation between the planimetric valves areas obtained by CT and MRI and the transesophageal echo. However, of course, the CT can't measure the gradients. So still the echo is superior in that sense. But cardiac CT also allows the evaluation of the mechanical aortic valve processes or any mechanical valve without artifacts that are seen in the echo, which would obstruct the echo evaluation. For endocarditis in patients with suspected infections, CT can be done to evaluate vegetations, infection sequels, valvular and paravalvular abscesses. Can also be seen, can all be seen in the CT. Cttavi Protocol. I think we all heard this term while ordering the CT before a TAVI procedure. Cttavi Protocol is a CT of the cardiac CT plus an aortogram. This allows for the assessment of the aortic root and the valve annulus in order to select an appropriate valve size and the location specific to the patient. It can measure the distance between the cusps and the coronary ostia to see if the patient is, to see if a TAVI is feasible in these patients. The aortic angiogram is also performed in order to determine the suitability of iliofemoral access, because it enables the detection of significant occlusive or aneurysmal disease of the access site or catheter route. This not only applies for the CT TAVI, it can also apply for any cardiac surgical procedure that would require peripheral cannulation. You can evaluate your cannulation site to go on peripheral bypass. It requires also a stable heart rate and ECG synchronization that is preferable for capturing a motionless aortic valve. The examination does require contrast and the patient cooperation to follow breathing instructions. CT for the aorta and great vessels. Non-contrast plane CT is considered the best imaging modality to see the aortic calcifications. If portions of the aorta are calcified on the CT, then aortic cross clamp and cannulation at those sites can be avoided to limit an embolic event or stroke. So it could really help the surgeon in guidance where to clamp and where to cannulate. Depending on the surgery planned, especially in aortic surgeries, CT angio can influence the cannulation site as well as the need for circulatory arrest or selective antigrade perfusion. Selective antigrade cerebral perfusion itself is dependent on intact right axillary and innominate arteries. So CT angio is optimal for defining this anatomy and making sure that all the vessels are patent without any disease. For aortic aneurysms, CT is the most accurate modality to evaluate the aortic root. The aortic root can be sized. Also, the exact location of the aneurysmal pathology can be evaluated. And the relation of the pathology to the valves and the sinotubular junction can be seen. And management planning can be based upon that. CT angio has sensitivity of and specificity of almost 100% for detection of aortic dissections and intramural hematomas. And it can also evaluate the extent of the intimal flap, especially with the addition of the ECG gating, the proximal extent of the dissection flap and its relationship to the coronary arteries and the aortic valves all can be evaluated. And the surgical plan can be revised based on that. Also, end organ perfusion can be assessed by the CT angio, and this is done by demonstrating the contrast enhancement of individual organs. In trauma patients, the sensitivity and specificity of CT are close to 100 in direct visualizations of traumatic aortic injury, grit vessels, and indirect signs, including widened mediastinum, pulmonary contusions, hemothorax, pseudoaneurysms of the aortic wall, and so on. For heart failure patients, especially the CT angio can be used for the LVAD assessment or any implantable device. CT is superior to echo in those patients because the limitation of echo in the image depth and coverage volume with regards to the limited acoustic windows and acoustic shadowing. CT can also detect common complications such as in-device thrombus formation, hemorrhage, cannular driveline obstructions, pericardium tamponade, or infections. In cardiac tumors, usually MRI is preferred, but CT also has a bigger role or a big role. It can be more feasible in patients who are claustrophobic or in hospitals who doesn't have the capability of performing MRIs. So CT can be used. It may be also required to evaluate the mediastinum or the chest wall or lungs, or if the patient has another contraindication to MRI, such an implantable device or any general contraindications for the MRI. It's all the same. So to talk about the cardiac MRI or CMR, it's the method of choice for assessment of functional and tissue properties of the heart, including the atrial and ventricular anatomy and motion and myocardial tissue compositions. CMR for myocardial disease. is the method of choice for assessment of functional and tissue properties of the heart, including atrial and ventricular anatomy and motion and myocardial tissue composition. The cardiac MR is performed both at rest and after pharmacological stress to evaluate for ischemia. The motion of the ventricular walls during systole and diastole is visualized, and the chambers can be assessed volumetrically. Perfusion cardiac MR is evaluated with the first pass of the gadolinium contrast. The cardiac MR is less practical than the CT angio for evaluating of the coronary arteries. The coronary MRI is less accurate and less used in diagnosing coronary stenosis and the coronary artery disease. CT is better. The cardiac MR is also the preferred imaging examination after echo in patients with suspected non-ischemic cardiomyopathy to diagnose the underlying etiology and to assess myocardial viability and function. Cardiac MR often also provides supportive evidence of myocarditis in patients with chest pain or heart failure symptoms, elevated troponin levels, and the non-ischemic ventricular dysfunction on echo. In assessing the valves, the cardiac MR is secondary to echo. It can assess valvular motion and enables visualization of flow dynamics for turbulent and quantification of regurgitations. For pericardial disease, cardiac MR enables direct visualization of the pericardium and is used in suspected underlying pericardial disease, such as recurrent pericarditis, constructive pericarditis, tumor invasions, or a congenital absence of the pericardium. These all can be evaluated with the cardiac MR. It's also the preferred examination of evaluating suspected cardiac tumors detected on echoes. It enables better characterizations of the tissue composition and perfusion. So when we talk about CT versus MRI in cardiac surgery, both modalities give us valuable pre- and post-operative informations. And although both technologies are evolving, and we don't know what the future will be, but at present, certain generalizations we can make. In favor of the CT coronary angio is more accurate in diagnosing coronary artery disease. The cardiac CT is crucial in preoperative cardiac surgery as it offers higher quality, non-invasive angiography of native coronary arteries and also for the bypass grafts after CABG. CT is preferred for preoperative planning, for reoperative CABG, for minimally invasive cardiac surgery. All calcifications are poorly seen on MRI, so CT is considered superior in demonstrating coronary myocardial, pericardial, and valvular calcifications. The same is true for mechanical valves and implantable devices because of large areas of artifact in the MRIs, and the functional evaluation is only possible with CT in those patients. Finally, all patients with the surgical problem of the aorta require evaluation with CT. In favor of the MRI, cardiac MRI is also important in assessing myocardial function, contractility, and actual tissue perfusion and viability. It distinguishes between the hibernating myocardium, the dead myocardium, and determines the need for intervention or not. So MRI remains the standard to assess ventricular volume, function, and myocardial mass. MRI can also assess areas of chronic myocardial infarctions, identify certain specific cardiomyopathies, and confirm the presence of neoplasms or tumors. In cardiac valves, if they're not mechanical, bioprosthetics and or native valves, they can be studied using the MRI with no problem. And thank you. That's the end of my topic.
Thank you so much, Dr. Abdelhadi, for your
Thank you.
presentation. I believe I have some questions. If you can only give me a summary out of the when I really should consider using or utilizing like CT scan in diagnosing coronary artery disease. Yes.
In diagnosing coronary artery disease, if the patient is of high risk, multiple comorbidities, and you suspect that he will have coronary artery disease, the picture is of typical acute coronary syndrome, typical chest pains. So it's no use of you going for the CT. You can go directly for the cath lab. However, this is important. The CT angio, the CT coronary angio is perfect for patients with stable chest pain. The young patients, you do not suspect coronary artery disease in these patients. It's less likely to be. They give a picture of a non-ischemic chest pain, but you still need to exclude the diagnosis. So those patients can go for a CT angio.
So if I'm using it to end up like what I know or the standard of care to diagnose coronary artery disease is not the CT not the CT angio.
It's not the CT angio.
So
and,
it is
even the results of CT angio is always compared with the gold standard, which is the invasive coronary angiography.
Okay, so in high risk patients, in which term? I mean, what high risk? What clinical scenario that can lead me to like disregard the coronary angio and utilize the CT angiogram instead? I mean, now I have a patient who's not typically having chest pain, but reporting an angina for like six months and follow up, and it is a time to make a definitive diagnosis whether this patient have coronary artery disease or not. Now, what things that lead me to use CT angiography instead of coronary cath lab coronary angiography?
So this patient is stable. You said he's been having this angina for 6 months. If he doesn't have any other comorbidities, diabetes, hypertension, risk factors for ischemic heart disease, if he doesn't complain of shortness of breath, the angina is not typical. So you can use the CT, especially as an outpatient. He doesn't need to be admitted, and it has a very high sensitivity. It can exclude the disease. So I would go for a CT angio in your patient, if he's, as I said.
I see. Also, I understand that like if I have a patient who is a renal failure patient or having a risk in accessing arterial access, or a patient who is having same as the scenario that we are discussing, with prior knowledge in echo, he has dissection, aortic dissection, or atheroma over the aortic valve. Then those are the things that I have to stop and think and use CT angio or consider CT angio instead of coronary angiogram. Yes.
Not instead, but probably you will have to do it definitely. If you might still need to do the coronary angiography. But CT can be just enough for them.
I see. Is there any question from the audience, do you have any questions or comments? Please go ahead. No questions. Dr. Khogir, do you mind to give us some comments, or if you have questions?
I think this is a very good presentation. It talks about all the aspects that we we apply, excuse me, CT scan and MRI and cardiac surgery. Just for the sake of completion, I would say if you put examples with pictures, because that's what we are facing in our life. We see some pictures of CT scan, and I'm talking about the resident, they need to know how to interpret those images. So the more images in this particular kind of presentation will be very beneficial for the resident. And if you, as a resident, encounter one of your patients going for CT or MRI, cardiac MRI, please make an effort to go downstairs and review those images with the radiologist. It will be a very good educational part of your residency. Thank you very much.
Thank you, Dr. Khogir.
Thank you so much, Dr. Abdelhadi. Thank you,
Thank you all.
audience, for the patient hearing. I believe we have 10 minutes or 15 minutes. I'm not sure about our host. 10 minutes or 15 minutes break, then we can start with the second lecture. Maybe Dr. Rasha can join us in moderation of the second lecture.
Muhammad?
Yes, sure. We'll start with work, inshallah.
So I think Faris will call Dr. Nalim because he's supposed to be with us, but we agreed that he will join at 2:30. So we'll just give him a call. We'll see if he's around, so we can start early, maybe after 10 minutes. So we'll give you an update in a minute.
Okay, no problem.
So we will resume the session at 2:20, inshallah.
So we can start now or wait?
I believe we will start at 2:30. Once Dr. Nazim Al-Akhras joined us, then we can proceed.
Okay.
So while waiting for Dr. Nazim, today was invited by the scientific committee of the Board of Cardiac Surgery. So we have discussed many issues regarding resident training. Maybe we'll have another session just for give you an update, but just an important announcement that this weekly quiz that we have established in the beginning of this academic year is now part of the evaluation of the residents. So just as like the attendance for this activity, solving the quiz before the deadline is also will be counted. You have to do 75% of these quizzes so you can get promoted. So from this week, this weekly quiz will be counted on the resident.
So the count will be only if done or not, or grade?
No, despite of the grade, just you have to do the quiz.
So can we extend the time for doing? Yani, I think if it is more than 100 questions, it need at least 4 days to be solved. And لو خلينا fixed every if we get the question Friday, Saturday, and we answer it until Wednesday, so I think it will be fair.
We will try to post the quiz on Thursday. The initial plan was to submit the quiz on Sunday, but it will be flexible. If we have an extra number of questions, we may extend the deadline because we need some time for analysis of the grades and finalizing the results. So these take some time as well. Also, in regards to the ECMO course, as I announced before, we have 6 seats available for non-King Faisal residents, and I have received only three names from the chief resident. So we have 3 slots available. So if anyone interested to attend, he can just post his name in our group and he will be counted. So the first 3 who post their name, they will be invited to the course.
Is it okay to attend the course from a resident outside Riyadh?
Yes.
مرحبا.
أهلا
بدأتوا؟
فراس.
يلا
دكتور فراس.
تفضل.
ايوه اهلا.
Could you project your slides, please?
Of course.
Thank you. If you allow me just to introduce Dr. Nazem Akhras. Actually, he is a consultant clinical pharmacist of cardiology at King Faisal. He's a consultant clinical pharmacist cardiology at Riyadh for the past almost 25 years, with a great experience and a great help always in the clinical areas to help in enhancing and improving the pharmacological part of the patient management. He is the residency program director for the past 10 years and more in our hospital. I believe Dr. Nazem Akhras will be a great help during this presentation for the discussion. If you have any question and comments with the Dr. Akhras, welcome, Dr. Nazem.
Thank you, Dr. Muhammad. I'm no longer the residency program director. My colleagues took over happily. I'm just now the clinical pharmacist cardiology. But it's nice to meet you. Inshallah, sometimes we'll see you soon face to face. And we wish you all successful residency fellowship. إن شاء الله بنشوفكم دكاترة جراحين كبار إن شاء الله.
Thank you so much, Dr. Nazem.
معلش يس دكتور، بس معنا بس اللي بيقول لي عشان اسوي شير لازم يكويت نفس الزوم عشان يسوي لي شير لنفس الجماعة، يعني تعذرون ثاني بس عشان يسوي شير.
Of course.
واضح كده خلاص؟
Yes, very clear.
Okay.
Dr. Rasha, if you can go ahead and moderate the session, have a good time.
Okay, yeah, so the second lecture will be inshallah cardiac pharmacology by Dr. Firas Abu Lainin. He is a resident in King Fahd Armed Force Hospital and will be inshallah supervised by Dr. Nazem Al Akhras. So Firas, if you're ready, you can start.
طيب. Assalamu alaikum. Good afternoon. I am Faris Abu Lainin, cardiac surgery resident R1 from King Fahd Armed Forces Hospital in Jeddah. And today I'm going to talk about the cardiac surgical pharmacology. But before I start, I just want to say thank you for giving us this opportunity to present in front of you respected doctors. And also I want to thank Dr. Nazem for his efforts and his valuable notes for helping me in this lecture. And lastly, I just want to say it is really an honor and true pleasure to be part of the cardiac surgery program and family. Okay, without further delay, I will start now. These are my objectives. I will start by an introduction, then I will go through antiplatelets, anticoagulants, fibrinolysis, antifibrinolytics, Endotropes, statin, beta blockers, calcium channel blockers, angiostatic converting enzyme inhibitors, and angiotensin receptor blockers, nitrates, diuretics, arrhythmia, and anti-arrhythmic. Then finally, I managed to put few MCQs if that's possible, if the time allows. I will go through it. Okay. Introduction. Clinical pharmacology associated with cardiac surgery is an important part of patient management. Patient in the perioperative period receive multiple agents that affect cardiovascular pulmonary function. Several basic subcellular and molecular pathways are important in cardiovascular pharmacology. The action potential in myocardial cells is a reflection of ion fluxes across the cell membrane. especially sodium, potassium, and calcium. Numerous drugs used to control heart rate and rhythm act by altering sodium like lidocaine and bromamide, or potassium like amiodarone, ibutylide, or sotalol, or calcium like diltiazem, altering their currents. Calcium also has a dominant effect on the inotropic state. Myocardial contractility is a manifestation of the interaction of actin and myosin with conversion of chemical energy from ATP hydrolysis into mechanical energy. The interaction of actin and myosin in myocyte is inhibited by the associated protein called tropomyosin. This inhibition is disinhibited by intracellular calcium. Thus, intercellular calcium has a tonic effect in both myocardium and vascular smooth muscle. Numerous of drugs used preoperative alter the intracellular calcium. Catecholamines like norepinephrine and dopamine with beta agonist activity regulate intramyocyte calcium levels via the nucleotide cyclic adenosine, which is cyclic AMP. In contrast to the myocyte in vascular smooth muscle, cyclic AMP has a primary effect of stimulating the uptake of calcium into intracellular storage site, decreasing its availability. Thus, drugs that stimulate cyclic AMP production, like beta agonists, or inhibit its breakdown, like phosphodiesterase inhibitors, will cause vasodilation. In addition, cyclic guanosine monophosphate, cyclic GMP, also increases the intracellular calcium storage, decreasing its availability for modulating the interaction of actin and myosin. Several commonly used pharmacological agents act via cyclic GMP. For example, we have nitric oxide stimulates the enzyme guanylate cyclase, increasing the cyclic GMP levels. And drugs such as nitroglycerin and sodium nitroprusside achieve their effect by producing nitric oxide as a metabolic product. The mechanism of action for control of heart rate, rhythm, and contractility and vascular tone are interrelated. For example, we have beta blockers or beta agonists, beta adrenergic agonists, not only increase the intracellular calcium to increase contractility, but they also alter potassium currents, leading to tachycardia. Also, catecholamines not only have beta adrenergic agonist activity with inotropic and chronotropic effects, but they also possess alpha agonist activity, leading to increased intracellular calcium in vascular smooth muscle and vasoconstriction. Also, phosphodiesterase inhibitors not only may increase contractility by increasing cyclic AMP in the myocyte, but they also may cause excessive vasodilation by increasing cyclic AMP in the vasculature. So this interplay of the various mechanisms means the clinical art of cardiac surgical pharmacology lies as much in selecting drugs for their side effects as for their primary therapeutic effects. Okay, hemostasis. Before I talk about the antiplatelets, I will just go through hemostasis as a quick recap. Hemostasis involve the interaction of several different systems to form a stable clot. We have vascular phase, platelet phase, clotting phase. In vascular phase, which occurs as an immediate response when a damage to a vessel wall induces neural reflexes and local myogenic spasm to reduce local blood flow. In platelet phase, which occurs when platelets come in contact with the endothelial collagen fibers of the damaged vessel. This in turn activates platelet aggregation mediated by ADP, thromboxane A2, von Willebrand factor, membrane glycoprotein 2B3A receptors, fibrinogen, serotonin, and platelet activating factor to form a loose platelet plug. Finally, we have the clotting phase, which occurs when the intrinsic and extrinsic pathways are activated to convert the loose platelet plug into a stable fibrin clot. Okay. Antiplatelets. Platelet aggregation inhibitors decrease formation of platelet-rich clot platelet-rich clot or decrease the action of chemical signals that promote platelet aggregation. The platelet aggregation inhibitors we will describe today inhibit cyclooxygenase 1, block glycoprotein 2B3A, or block the ADP receptors, thereby interfering with the signals that promote platelet aggregation. These agents are beneficial in the prevention and treatment of the occlusive cardiovascular diseases and in the maintenance of vascular grafts and arterial patency, and as adjuvants to thrombin inhibitors or thrombolytic therapy in MI. Okay, I will start by aspirin. Class of drug, it is cyclooxygenase inhibitor. Mechanism of action, aspirin inhibits platelet cyclooxygenase, thereby reducing the production of thromboxane A2 and platelet adhesiveness. The indication of aspirin include primary and secondary prevention of cardiovascular and cerebrovascular diseases. The dose of aspirin is between 75 and 150 milligram as prophylaxis and up to 300 milligrams for therapeutic effect in myocardial infarction. P212 receptor antagonist, like we have Taclobadine and clopidogrel, prasugrel, ticagrelor, and cangrelor, are P2Y12 ADP receptor inhibitors that also block platelet aggregation, but by a mechanism different than from that of aspirin. All of these agents are administered orally with the exception of cangrelor, which is an injectable formulation. Okay, the mechanism of action. These drugs inhibit the binding of ADP to the P2Y12 receptor on platelets and thereby inhibit the activation of glycoprotein 2B3A receptor required for platelet to bind to fibrinogen and to each other. Ticagrelor and cangrelor bind to the P2Y12 ADP receptor in a reversible manner. The other agents bind irreversibly. The maximal inhibition of platelet aggregation is achieved in 2 minutes with IV cangrelor, 1 to 3 hours with ticagrelor, 2 to 4 hours with prasugrel, 3 to 4 days with Taclobadine, and 3 to 5 days with clopidogrel. When treatment is suspended, the platelet system requires time to recover. Okay, the indication of this agent include clopidogrel is approved for prevention of atherosclerotic events in patients with recent MI or stroke and in those with established peripheral arterial disease, and also approved for prophylaxis of thrombotic events in acute coronary syndrome like unstable angina or non-STEMI. Additionally, clopidogrel is used to prevent thrombotic events associated with percutaneous coronary intervention, PCI, with or without coronary stenting. Taclobadine is similar in structure to clopidogrel. It is indicated for the prevention of TIA, transient ischemic attacks and strokes in patients with a prior cerebral thrombotic event. However, due to life-threatening hematologic adverse reaction, Taclobadine is generally reserved for patients who are intolerant to other therapies. Prasugrel is approved to decrease thrombotic cardiovascular events in patients with acute coronary syndrome, unstable angina, non-STEMI, and ST elevation MI managed with PCI. Ticagrelor is approved for the prevention of arterial thromboembolism in patients with unstable angina and acute MI, including those undergoing PCI. Cangrelor is approved as adjuvant during PCI to reduce thrombotic events in select patients. Okay. We have glycoprotein 2B3A. The mechanism of action, the glycoprotein 2B3A receptor plays a key role in stimulating platelet irrigation. A monoclonal antibody fragment, abciximab, inhibits the glycoprotein 2B3A receptor complex. By binding to the glycoprotein 2B3A, abciximab blocks the binding of fibrinogen and von Willebrand factor, and consequently aggregation does not occur. Ibipitide and tirofiban act similarly to abciximab by blocking glycoprotein 2B3A receptor. Ibipitide is a cyclic peptide that binds to glycoprotein 2B3A at the site that interacts with arginine, glycine, aspartic acid sequence of fibrinogen. Tirofiban is not a peptide, but it blocks the same site as ibipitide. Okay, the indication, these agents are given IV along with heparin and aspirin as an adjunct to BCI for the prevention of cardiac ischemic complication. Abciximab is also approved for patients with unstable angina, not responding to conventional medical therapy when BCI is planned within 24 hours. Okay, regarding the dose, abciximab, the dose is 250 milligrams per kg IV bolus, then 125 nanogram per kg per minute IV infusion. Tirofibran is 400 nanogram per kg per minute for 30 minutes, then 100 nanogram per kg per minute as IV infusion. Okay, now this is just a summary of the characteristics of platelet irrigation inhibitors. We have first aspirin, the targets we mentioned before, cyclooxygenase inhibitor 1, and thromboxane A2. At the time from last dose to offset, it needs 7 to 10 days. We use it, as we mentioned, primary prevention, ICS, stable angina, BAS, and recent stroke, and side effects, angioedema, bleeding, bronchospasm, GI disturbance, Reye syndrome, Stevens-Johnson syndrome. The drug interactions include ketaloric will increase bleeding, cidofovir will cause nephrotoxicity, probenecid decrease the urosoric effects, non-selective COX-1 inhibitors decrease aspirin efficacy. And also we need to monitor the CBC and liver function test. Regarding the clopidogrel, it's P212 DB receptor, half-life of 6 to 8 hours. Also the time from last dose to offset 7 to 10 days. And we use it for non-STEMI, STEMI, BCI, recent stroke, or established PDA. Side effects could be bleeding or Stevens-Johnson syndrome. Drug interaction include strong CYP2C19 inhibitors reduce antiplatelet effect, for example, like omeprazole. Also, here we need to monitor the CBC and liver function test. Okay. Also, here we have the other B2Y12 ADP receptor, prasugrel. It's 8 hours as a half-life, and it's 8 hours from half-life, and time from offset, last dose to offset is 2 to 3 days. And we use it for patients undergoing with ACS, undergoing BCI. Its side effects could include angioedema, bleeding, headache, hyperlipidemia, hypertension. Interaction include anticoagulants, other antiplatelet, non-genetic polymorphism influence. We need also to monitor CBC here. Taclobadine. Also the target is B2Y12 ADP receptor, half-life 12 hours. The last dose to offset is 7 to 8 days. We could use it in transient ischemic attacks, patient undergoing BCI. Side effects include abnormal liver function test, bleeding, dizziness, GI disturbance, Stevens-Johnson syndrome. Interaction include anti-acid decrease its level, cimetidine reduces clearance. And also we need to monitor here CBC liver function test in addition to platelet count. Ticagrelor is also the target, B2Y12 ADP receptor, half-life of 6 to 12 hours. The time between the last dose to offset 5 days. We use it in STEMI, elevation MI, ACS, BCI. And the side effects include bleeding, dyspnea, headache, raised serum creatinine. The interaction include strong CYP3A4 inhibitors, for example, like ketonazole, ritonavir or clarithromycin, and also CYP304 inducer, for example, rifampin, phenytoin, carbamazepine, and dexamethasone. We also here need to monitor the CBC and liver function test. Injectable agent, abciximab, ABT fibatide, and tirofibran. Target glycoprotein 2B3A. Half-life of abciximab between 10 to 30 minutes, or maybe below 10 minutes. Eptifibatide is approximately 2.5 hours, tirofibran 2 hours. It's the time between the last dose to offset is 12 hours. We could use it in non-STEMI BCI and stable angina. For all agents, side effects include hypotension, nausea, vomiting, thrombocytopenia, and also in the interaction for all agents include increasing bleeding, ginkgo biloba, anti-blessed salicylate, and selective serotonin reuptake inhibitors and serotonin or epinephrine reuptake inhibitors. For all agent, also here we need to monitor activated partial thromboplastin time, clotting time, hematocrit and hemoglobin, platelet count, and lastly thrombin time. Okay, anticoagulants. I will start by
can we take a minute here? So if you can, Faris, maybe after each session or each class, just ask if there's any questions, and maybe we can take a few minutes to comment on some of the information.
Course, yes.
So if anybody have any question. If nobody have any questions, I have a few comments about the antiplatelet as a class effect. Now we're using double or triple antiplatelet in acute coronary syndromes, and some of them are, they affect the platelet, the circulating platelets for the duration of the lifespan of the platelet. Like abciximab, the half-life is very short, but it affects all platelets because it's a monoclonal antibody. So if somebody is going for a procedure immediately after receiving abciximab, that patient may need platelet transfusion regardless of that platelet number. Eptifibatide and tirofiban, they are very short acting. So 4 hours before the procedure can be stopped and the patient can go for surgery relatively safely. The P212s, do we hold aspirin? First of all, aspirin. Do we hold aspirin before surgery?
No.
Yeah, aspirin should not be held in cardiac and non-cardiac surgery if the bleeding risk is relatively acceptable. There is always some bleeding risk, but if it's acceptable, we do not, except maybe in neurosurgical procedures. But aspirin nowadays, it's not recommended to stop it in patients with acute coronary syndrome or patients with the ischemic heart disease. And cardiac surgery is not an exception. The patient should go to surgery on aspirin. Now, what about P212? Taclobadine actually is hardly used anymore, and I'm not sure if it's still available because of its leukopenia. It causes significant leukopenia. The white cells drop significantly. So it's not used anymore since we have alternative, prasugrel, clopidogrel, and ticagrelor. The clopidogrel is usually the alternative to ticagrelor in patients with the stroke and TIA. Now, it's important to know the holding period for each of these. So for clopidogrel, we hold for how long?
5 days.
Before surgery. Yeah, ideally 5 days, at least minimum 3 days. If it's urgent, then they just have to, the anesthesiologist have to deal with it and do the best they can to control bleeding. Ticagrelor is also 5 days. Prasugrel should be 7 days ideally. So for procedures, for cardiac and non-cardiac procedures, they should be held. Now for elective procedures, ideally also in patients with stenting who received stenting, especially within 3 months, should be postponed, whatever procedure they need. If it's urgent, then ideally you should admit the patient and monitor them in the hospital. Okay.
Yes, thank you, Dr. Nadam, for your valuable comment.
دكتور ناظم.
Okay, and
Sam.
Yeah, sorry. دكتور عبد الله معك الله يعطيك العافية. أقول لك دكتور, you know, patients with PLAVIC, sometimes we hold it for 5 days and still there is we get some kind of bleeding intra-op. So what's your comment on that?
Yeah, it's the patient is on clopidogrel, and most of the platelet will be affected. It's for the lifespan of the platelet. Now we produce around 11,000 platelets per day. So if the patient was held for like 3 to 5 days, the lifespan of the platelets is 7 to 10 days. So the patient may still have some effect hanging on the platelets, the circulating platelets, especially if the platelet count is low. And that's why if the patient goes for surgery, maybe a fresh platelet can be given to minimize the bleeding.
I mean, isn't it that we should just advise for a longer period of hold to be held longer than 5 days?
No, from clinical trials, from the half-life of the drugs, 5 days should be reasonable. This is the recommendation by platelet assays and by guidelines. Now, patients may have other reasons for bleeding. Maybe they have bleeding diatheses, maybe they have antithrombin deficiency or other forms, Van Willebrand or something like this, or may have other compounding variable like uremia, patients with end-stage renal disease or with very high urea. These patients, their platelets are non-functioning relatively, or if they have hematologic conditions, leukemia or something like this. But in general, this is the guideline recommended timing for holding the P2Y12s. Clopidogrel is 5 days, ticagrelor is at least 3 to 5 days, and prasugrel is 7 days.
I see. Thank you, Doctor.
Sure.
Okay, thank you, Dr. Nadam. Any other question or comment? Okay, anticoagulants. First, I will just briefly talk about the clotting cascade. The clotting cascade involves the activation of number of coagulation factors, which is serine proteases, resulting in fibrin or clot formation. And it is controlled by the intrinsic pathway, which is the contact activation pathway, or the intrinsic pathway activated or stimulated by exposure of blood to negatively charged surface. For example, like in the vessel wall, if the endothelial lining becomes damaged. Then we have the extrinsic pathway, tissue factor pathway, which is activated by tissue factor released by the endothelium following vessel damage and stimulated by exposure of blood to material outside the vessel. For example, like foreign body that has lacerated the vessel. And finally, we have the final common pathway, which is activated by either the intrinsic or extrinsic pathways and results in fibrin formation. Also, there are a number of cofactors that play an important role in the coagulation cascade. We have calcium and vitamin K. Calcium, which is required by kinase and prothrombinase to convert prothrombin into thrombin, and vitamin K, which is required by the liver for the production of factor 2, 7, 9, and 9, 10, and as well as protein C and S. Also, there are a number of inherited regulators circulating that control the coagulation cascade. We have protein C, antithrombin 3, prostacyclin, tissue factor pathway inhibitor, and plasmine. Protein C, which inactivates factor 5 and factor 8 in the presence of protein C. Antithrombin 3, which is a serine protease inhibitor secreted by the endothelium and inhibits thrombin and factor 9, 10, and 11. Prostacyclin, which inhibits platelet aggregation and causes vasodilation. Tissue factor pathway inhibitor, which is produced by platelets and inhibit factor 5 and 7. Okay, heparin. Heparin is mucopolysaccharide that is indirectly inhibits factor 10 and 2, binds to antithrombin to potentiate its effect. The indication of heparin include treatment and prophylaxis of DVT, pulmonary embolism, and stable angina, anticoagulation during cardiopulmonary bypass, temporary anticoagulation for prostatic valve patient. We should be cautious in a patient with active bleeding. The side effects of heparin includes hemorrhage, hyperkalemia, osteoporosis, thrombocytopenia, and hypersensitivity. The dose of heparin as prophylactic 5,000 units BID sub-Q. For the therapeutic causes 5,000 units or 75 units per kg IV loading dose, followed by an infusion of 18 units per kg per hour. On full cardiopulmonary bypass, we use 300 units per kg bolus, minimal extracorporeal circulation 200 units per kg. If of pump cabbage, we use 100 units per kg. Heparin can be reversed with protamine sulfate, and since I mentioned protamine sulfate, I will talk about it in brief. Protamine sulfate is a cation derived from salmon sperm that binds with the anion heparin to form stable heparin protamine complexes. Protamine contains two active sites, one for neutralizing heparin and one which has mild anticoagulant effect. For each 1 milligram, 100 units of heparin administered initially 1 milligram of protamine, maximum 3 milligrams per kg should be injected IV to reverse the anticoagulant effect. We should be aware of heparin rebound. It might occur once all of the protamine is bound by circulating heparin, and further tissue heparin is released, maintaining the anticoagulant effect. In this situation, a further dose of protamine, 50 milligrams, may be required. Protamine should be given as a slow infusion over 15 minutes to reduce the risk of protamine reactions. Okay, protamine reactions. We have Horo classification of protamine reaction. We have class 1. Class 1 is a hypotension caused by rapid administration of protamine. That's why we have to give it in a slow fusion. This is triggered by histamine release and can usually be treated by simple fluid resuscitation and vasopressor. Class 2 anaphylactic reaction, we have 2A, 2B, 2C. 2A is a true anaphylaxis, hypotension, bronchospasm, and angioedema mediated by anti-protamine immunoglobulin A, antibody, and histamine, prostaglandins, and kinins. It occurs in diabetes whom are on protamine, zinc, and serine, patients with fish allergies, and those who have been exposed to protamine previously. It should be treated by immediately stopping the protamine and administering 10 ml 1 to 1,000 100,000 IV adrenaline, 100 milligrams IV hydrocortisone, 10 milligrams IV chlorophenamine, and 100% oxygen and nebulized bronchodilators. We have also 2B, 2C, 2B immediate anaphylactoid, and the 2C delayed anaphylactoid. Okay, lastly, we have class 3. Class 3 is catastrophic pulmonary vasoconstriction. It's caused by complement activation and the release of thromboxane A2. This results in right ventricular failure, circulatory shock, and severe bronchospasm. The treatment includes immediately stop the protamine also, the administration of 10 ml 1 to 100,000 IV adrenaline, millirenal, and resuscitation cardiopulmonary bypass if the patient was on one. Okay. Now, okay, I will talk about low molecular weight heparin. Low molecular weight heparin has similar action to heparin, except low molecular weight heparin has a longer half-life than heparin. Low molecular weight does not require monitoring. Activated partial thromboplastin time is unaffected. Low molecular weight heparin has a greater anti-factor 10 activity. Low molecular weight heparin has a lower incidence of thrombocytopenia and osteoporosis. Indication of low molecular weight include acute coronary syndrome and prophylaxis for DVT. Cautions include active bleeding. Side effects of low molecular weight heparin include hemorrhage, same as heparin, hemorrhage, hyperkalemia, osteoporosis, thrombocytopenia, and hypersensitivity. The dose, Deltabarin therapeutic dose, 120 units per kg by D sub-Q, or as prophylactic 5,000 units once daily sub-Q. For the enoxaparin, therapeutic 1 milligram per kg by D sub-Q, and as prophylactic between 20 and 40 milligrams OD sub-Q. Okay. Fondaparinux. Fondaparinux is a synthetically derived pentasaccharide anticoagulant that selectively inhibits factor 10 by selectively binding to anti-thrombin 3. Fondaparinux potentiates 300 to 1,000 fold to the innate neutralization of factor 10 by anti-thrombin 3. Fondaparinux is approved for the use in the treatment of DVT and BE, and for the prophylaxis of venous thromboembolism in the setting of orthopedic and abdominal surgery. Okay, the drug is well absorbed from the subcutaneous route with a predictable pharmacokinetics profile, and therefore require less monitoring than heparin. Fondaparinux also is eliminated in the urine mainly as an changed drug with an elimination half-life of 17 to 21 hours. In the contraindication, it is contraindicated in patients with severe renal impairment. Regarding side effects, bleeding is the major side effect of Fondaparinux. There are also no reversible no available agent for the reversal of bleeding associated with Fondaparinux, but heparin and induced thrombocytopenia is less likely with Fondaparinux than with heparin, but it is still a possibility. Okay, here we have a table, just a quick summary or sum up between the differences between heparin and low molecular weight heparin. In the terms of application, heparin can be given sub-Q or IV. Therapeutic administration requires infusion bulb. But in low molecular weight heparin, administration always sub-Q. In dosing, low dose sub-Q, regarding heparin, low dose sub-Q administration every 8 to 12 hours. In high doses, IV administration with bolus and continuous application via infusion bulb. But in low molecular weight heparin, dosage depends on specific drug use, indication, body weight, and kidney function, and adjust to body weight and decrease kidney function. The advantages of unfractionated heparin, adequate anticoagulation is achieved sooner due to direct effect on thrombin, and protamine, the antidote, antagonizes the effect of unfractionated heparin. The advantages of low molecular weight heparin, effect of low molecular weight heparin lasts for about 12 hours. Monitoring of anti-factor 10 is only necessary in patients with decreased kidney function and significant over or underweight. Anti-factor 10 activity is measured 4 hours after administration. Okay, regarding the limitation, the heparin has short half-life, means anticoagulant effect quickly ceases once stopped. If used therapeutically, used in the therapeutic manner, PTT levels should have to be monitored. Frequency target range between 1.5 to 2.5 fold prolongation in comparison with low molecular weight heparin. Type 2 heparin-induced thrombocytopenia is about 10-fold more common. Severe bleeding is more common, but the limitation regarding the low molecular weight heparin use cautiously in renal failure because it's renal inflammation. It is contraindicated in renal if renal function is poor, creating clearance below 30 ml per minute. There is no full antagonist available. Okay, preferred use, we use heparin in emergency, more easily titrated, available as a IV infusion. For patients with advanced renal failure, like in patient with severe renal insufficiency and has creatine clearance below 30 ml per minute, or the elderly. Preferred use for low molecular weight heparin, DVT prophylaxis, outpatient care, longer because have longer half-life and fewer injections. Generally preferred to unfractionated heparin because has fewer side effects, easier handling, as long as there are no contraindications. Okay, any questions or comment before I go to direct thrombin inhibitors?
Maybe we can go through the direct thrombin inhibitors because also IV anticoagulants.
I'm sorry, I didn't hear.
Yeah, go ahead, finish the direct thrombin inhibitors.
Okay, direct thrombin inhibitors. First, we have argatroban. The mechanism of action. Argatroban is a synthetic parenteral anticoagulant that is derived from L-arginine. It is a direct thrombin inhibitor. Argatroban is used for the prophylaxis or treatment of venous thromboembolism in patients with heparin-induced thrombocytopenia, and also is approved for using during PCI in patients who have or at risk for developing heparin-induced thrombocytopenia. Anticoagulant effect of argatroban are immediate. Argatroban are metabolized in the liver and has half-life of about 39 to 51 minutes. Dose reduction is recommended for patients with hepatic impairment. Monitoring include activated partial thromboplastin time, hemoglobin, hematocrit, as with other anticoagulants. Also here, the major side effect of argatroban is bleeding. Okay. We have now bifvalirudin and dizarudin. Bifvalirudin and dizarudin are parenteral anticoagulants that are analogs of herodin. Thrombin inhibitors derived from saliva of the medicinal leech. These drugs are selective direct thrombin inhibitors that reversibly inhibit the catalytic site of both free and clot-bound thrombin. Okay, an indication bifvalirudin is an alternative to heparin in patients undergoing PCI who have or are at risk of developing heparin-induced thrombocytopenia, and also in patients with unstable angina undergoing angioplasty. Dizarudin is indicated for the prevention of DVT in patients undergoing hip replacement surgery. In patients with normal renal function, the half-life of bifvalirudin is 25 minutes. Dose adjustments are required in patients with renal impairment. Like others, the major side effect is bleeding here. Okay, now we will go through Warfarin. Should I go? Well,
I think let's stop here. This is the injectable anticoagulants.
Yes.
If they have any questions, comments.
for 2 days maximum. That's our level. Yes. TID.
So it's just a couple comments. As you Faris mentioned, heparin is the drug of choice for patients with advanced renal failure and during cardiopulmonary bypass. Most of the time we have to check the ACT or check the PTT frequently because there's variation in patient response. So there's a lot of protein binding to it also and antibodies. So the PTT should be checked every 4 hours. This is outside the OR. In the cath lab and the OR, ACT is checked and the dose is adjusted accordingly. If nobody have any questions, we can proceed. Maybe just in patients with true HIT type 2, that it's still active and the patient need to go to surgery, then bivalirudin or argatroban can be used, and there's a protocol for that, for during bypass. Otherwise, if the patient has history of HIT, but the patient currently, there is no antibody. So when we check HIT antibody, the pathologists do not see any antibody and they reported negative. Then the patient can go on heparin during the bypass, but immediately after that should be switched to either argatroban or bivalirudin if the patient has documented HIT type 2, which is the immune type reaction. Okay.
Yes.
So what about if the patient have HIT immune type, and is there a role for plasmapheresis pre-op?
If it's catastrophic, there is a catastrophic HIT antibody where there is thrombosis. The problem with HIT type 2 is not bleeding. The platelet go down to 10 or 15, less than 50 usually we say. But the problem is not bleeding, the problem is thrombosis. So that's why you need to start a form of anticoagulant, direct thrombin inhibitor, to prevent the thrombosis. Now, if this is catastrophic type of HIT type 2, yes, plasma exchange can be done to remove some of the antibodies, along with direct thrombin inhibitors.
No, I mean to do it plasma exchange to facilitate the use of heparin intra-op.
If there is no thrombosis, I would no. There's no indication. If there is no thrombosis, just start argatroban or bivalirudin, wherever your hospital. At King Faisal, we have argatroban. We don't have bivalirudin. So you can start argatroban and keep argatroban until the platelets above 100. Then if the patient needs further anticoagulants, like mechanical valves or so, then you start warfarin and you keep argatroban until the INR, with argatroban actually above 4. Then you stop, because argatroban give you a false increase in the INR. If the patient does not need long-term anticoagulation, maybe just DVT prophylaxis, then maybe I would use fondaparinux, because fondaparinux is does not cause HIT antibody. There's a cross reaction with the enoxaparin, low molecular weight heparins, but not with fondaparinux, the synthetic indirect anti-10A. Okay.
Okay, thank you, Dr.
If you allow me, Dr. Now. I have a question regarding the heparin reversal with protamine. So if we have a patient who has a reaction to protamine, so what is the alternative to protamine to reverse the heparin?
Heparin is very short acting. I would just, if the patient is not bleeding or just supportive care. Fresh frozen plasma you can give sometimes, but it's not. I think in the OR they use thromboplasm. I mean the machine. I forget what it's called, and they can tell which part of the hemostasis is deficient, and they can give that.
Yeah.
But there, heparin is short acting. Within 90 minutes or less, most of the heparin will be gone. But in patients on the OR table, because they give so much, very high doses to maintain ACT 300 to 500, just monitor the ACT and see. To be honest with you, I've never seen the reaction. I don't know if the anesthesiologists have seen protamine reaction or not. It's reported in the literature and reported in textbooks and in the drug references, but I've never seen a reaction myself.
Yes, great.
If I may, Walid today gives in the morning the lecture about protamine, and was suggested. Walid, go ahead if you want to comment on that. You said there is drugs under trial to alternatives to protamine in terms of if they have other reaction or something.
Yeah, so when I looked into this topic, protamine reversal, there are a few agents that are under study. One of them is called heparinase. Heparinase is an enzyme that is used to cleave heparin from antithrombin 3. Another one is called bulibrine or dimetherine. This is a previous drug that used to be used before the discovery of protamine. So sometimes it can be used, however, it has issues with nephrotoxicity. Last thing that is under study is recombinant platelet factor 4, which is naturally occurring in alpha granules of platelet. There's a recombinant form for that, and it's under studies for efficacy for reversal of heparin. Another thing is actually there's a way to never mind. There's another thing, but I don't remember enough details about it. Thank you.
Yeah, I'm not sure if any of these commercially available. I mean, there is always research protocols or something like this. I'm not sure if any of these currently available for commercial use. Like I said, heparin is usually it's mainly related to how fast they administer. I don't know. I'm sure the anesthesiologist they're much more familiar with this because they deal with it and they always give this during the OR. In clinical practice, we rarely give protamine to any patient because even if we administer the PTT is very high, we don't administer really protamine for correcting a PTT. So it's not in clinical practice. We don't use protamine or reverse heparin. It can only be, I mean, maybe it's used in overdoses by mistake, like they administer heparin instead of something else to the patient who does not need anticoagulation. One thing about heparin monitoring, which is very important, I faced this myself last week with a patient who had stuck valve. Those patients with lupus anticoagulant positive, it's very difficult to anticoagulate them. And actually, and patients, similarly, patients on ECMO or on extracorporeal oxygenators, it's better to follow the anti-10A level, which is another name for heparin assay. That will give you much more feel for how much is the anticoagulation the patient's getting, because with lupus anticoagulant, they have pre-existing high PTT. So I reached on one of the patients, I reached a PTT ratio of 4. APTT is more than 100, 120, and the patient was 0 heparin assay or 0 anti-10A level. And that's the problem with the disease itself. So another way of monitoring, but this is not for OR monitoring because you need the results immediately. So this is for patients on the floor or on the CSICU post-operative. Okay.
Okay, should I continue?
Continue, Faris.
Okay. Okay, now I will talk about warfarin. Warfarin is a coumarin derivative that interferes with vitamin K metabolism. Vitamin K is a cofactor in the hepatic production of numerous protein, including coagulation factors, as we mentioned before. Vitamin K, such as vitamin K antagonists, such as warfarin, inhibit the enzyme vitamin K epoxide reductase, thereby blocking hepatic synthesis of the active reduced form of vitamin K needed for the carboxylation of coagulation factors 2, 7, 9, 10, and protein C and S, as we mentioned before. Regarding the indication of warfarin, we can use it for prophylaxis and treatment for the thromboembolism with DVT, pulmonary embolism, atrial fibrillation, mechanical prosthetic valves, left ventricular thrombus, and transient ischemic attacks. The cautions include hepatic impairment, peptic ulcer disease, and also warfarin interacts with numerous drugs because warfarin is metabolized by the cytochrome B450. Its effect can be significantly impacted by a variety of interactions. For this reason, warfarin serum levels should be monitored regularly. Decrease the anticoagulant effect can be with rifampicin, carbamazepine. They induce metabolic breakdown of warfarin via the induction of cytochrome B450. We have also food rich in vitamin K like kale or sabanich. Counter effect of warfarin, gastric acid inhibition with BBI use or cholestyramine treatment will impair the uptake of warfarin. Okay, regarding the increased effect of anticoagulant, we have several antidepressants, antibiotics, BBI also, amiodarone, grapefruit. It will impair metabolic breakdown via inhibition of cytochrome B450. Acetaminophen metabolites interrupts vitamin K cycle via inhibition vitamin K dependent carboxylase. Also sulfonamides and sulfonylureas competitively block or displace warfarin at plasma protein binding sites. Also damage to gut flora like in antibiotic therapy, impaired bacterial vitamin K synthesis. Side effects of warfarin, hemorrhage. The dose depend on the international normalized ratio, INR, with most indication aiming for INR of 2 to 3, except in patients with mechanical mitral valves, INR between 2.5 to 3.5, 2.5 to 3.5. Warfarin can be reversed with vitamin K fresh frozen plasma or beriplex, which is a human prothrombin complex concentrate. Okay. Here we have a table of overview commonly used oral anticoagulants. we have warfarin vitamin K antagonist, and we have non-vitamin K antagonist, oral anticoagulants like NOACs or novel oral anticoagulants like dabigatran and rivaroxaban have gained popularity in recent years. The novel oral anticoagulants act selectively via inhibition of thrombin like dabigatran or factor 10 like rivaroxaban, apixaban, or dexaban. Because of their short half-life and fewer interactions, novel oral anticoagulants are easier to control and administer than warfarin and do not require a regular monitoring to ensure efficacy and safety. So let's look now. Regarding the mechanism of action, we already talked about warfarin. It inhibits hepatic vitamin K, epoxide reductase, decrease the hepatic synthesis or recycling of the active reduced form of vitamin K, decrease the carboxylation of glutamate residues of coagulation factors 2, 7, 9, 10, as well protein C and S. Also, the direct oral anticoagulants like dabigatran, it's selective thrombin antagonist, and the apixaban, rivaroxaban, edoxaban is selective and direct inhibition of factor 10. Okay, the advantages of vitamin K antagonists like warfarin are disadvantages. Vitamin K antagonist has well-known effects and side effects. It has low cost also. In cases of life-threatening bleeding, there is a non-direct reversal by the replacement prothrombin complex concentrate or fresh frozen plasma, or indirect delayed reversal by increasing production of coagulation factor with vitamin K substitution. But the disadvantages of warfarin, it's difficult to manage, or in general, vitamin K antagonist is difficult to manage, longer half-life, regular monitoring of the BT-INR required, as vitamin K antagonist affects the extrinsic coagulation pathway, requires bridging before surgery, broad range of interaction, as we talked about before, not suited for acute therapy of PE or DVT. And regarding the advantages and disadvantages of the direct oral anticoagulant, it is easy manageable, similar to heparins when administered orally. Require monitoring of coagulation parameters is not required. Means require monitoring of coagulation parameters not required. Improves patient compliance. This will improve the patient compliance. Antidotes available in case of life-threatening bleeding. Dabigatran, we have daruzumab, and it is a monoclonal antibody. And for apixaban and rivaroxaban, we have andexanate alpha. But the disadvantages of them they are costly, limited clinical experience with these drugs, not recommended, and partially contraindicated in patients with artificial cardiac valves, not suited for patients with valvular atrial fibrillation. Okay. The indication of vitamin K antagonist, as we mentioned before, prophylaxis from embolism like stroke in patients with following valvular atrial fibrillation, non-valvular atrial fibrillation, heart valve replacement, heart failure, myocardial ischemia, and started target of INR we mentioned before, most of between 2 and 3, except in mitral mechanical valves between 2.5 to 3.5. And the indication of direct oral anticoagulants, non-valvular atrial fibrillation. Also, both of them, it can use therapy and secondary prophylaxis of DVT, pulmonary embolism, and prophylaxis of thromboembolism following total knee hip replacement or hip fracture surgery. Okay, this is just a sum up between heparin and warfarin. Route of administration, heparin can be given as we mentioned before, IV and or sub-Q. Warfarin is oral agent. Mechanism of action, heparin is activates antithrombin, decrease the action of factor 2 and 10. The site of action is blood for heparin, rapid onset of action, shorter half-life, duration of action, shorter duration of action, several hours. Regarding warfarin, as we mentioned before, the mechanism of action decreases the synthesis of factor 2, 7, 9, 10 procoagulants and protein C and S, anticoagulants. The site of action in liver, slow onset of action, longer half-time, duration of action is several days. In heparin, we need to monitor BTT, affects the intrinsic pathway, and for warfarin, we need to monitor BT and or INR because it affects the extrinsic pathway. Reversal agent for heparin, we talked about protamine sulfate, and for warfarin, vitamin K, fresh frozen plasma, BCC for rapid reversal. Okay, fibrinolysis and anti-fibrinolytic. Any question or comment before I go on?
Just one comment for me regarding use of analgesics with the warfarin. Acetaminophen actually is the safest, and the interaction is not that prominent interaction, so you can safely give acetaminophen. On the contrary, if you give non-steroidal, the patient will be at higher risk of bleeding and increase the INR.
Yes. Okay, thank you, Dr. Nadim.
Sure. So if there is no questions, we can proceed. Go ahead.
Okay. Okay, now we'll talk about fibrinolysis. Fibrinolysis is the process of clot breakdown and is primarily controlled by plasmine. Plasmine is a serine protease that is synthesized in the liver as an active plasminogen. And the main function is to break down the unstable bonds between fibrin molecules to generate fibrin degradation products. It is activated by tissue plasminogen activator TPA, urokinase, thrombin, fibrin, and factor 7, and it is inactivated by alpha-2, antiplasmin, and serpin. It occurs at the same time as fibrin formation to limit thrombus production locally. Okay, fibrinolytics. The mechanism of action of fibrinolysis convert plasminogen to plasmine, which in turn degrades fibrin-containing thrombi. These drugs are subdivided into non-specific thrombolytic agents such as streptokinase and fibrin-specific agents such as recombinant tissue plasminogen activator and tenecteplase. The indication include acute MI, acute myocardial infarction, acute pulmonary embolism, and a thrombosed cardiac valve. The cautions, I will talk about it in the next slide. The side effects include hemorrhage, including cerebral hemorrhage, hypersensitivity, and systemic emboli, which occurs following clot lysis. The dose of streptokinase for MI is 1.5 million units. And here are the cautions. It's according to European Society of Cardiology 2017. We have absolute and relative contraindication. Absolute contraindication include prior intracranial hemorrhage or stroke of unknown origin at any time, ischemic stroke in previous 6 months, CNS damage on neoplasm or AV malformation, GI bleeding within the past month, following non-bleeding disorder except menses, aortic dissection, non-compressible puncture in the past 24 hours, like liver biopsy or lumbar puncture. This is regarding the absolute contraindication. Regarding the relative contraindication, TIA in previous 6 months, oral anticoagulant therapy, pregnancy or 1 week postpartum, refractory hypertension, systolic blood pressure more than 180 millimeter of mercury, or diastolic blood pressure more than 110, advanced liver disease, infective endocarditis, active peptic ulcer disease, prolonged or traumatic resuscitation. Okay. Here we have the comparison of different types of fibrinolytics. We have streptokinase first. It's first generation, 1.5 million units in 30 to 60 minutes. In 60 minutes, it has high antigenicity. It has allergic reaction use in dose-related hypotension, and it's low fibrin specificity. And it's half-life 30 minutes and uses for acute MI DVT also. And urokinase, it's a human enzyme found in urine. It's first generation. The dose is 4,400 international units per kg IV at a rate of 90 ml per hour in 10 minutes. It has also low antigenicity, no allergic reaction, also a low fibrin specificity, and half-life of 20 minutes. We can use it in acute massive pulmonary emboli or acute MI. We have alteplase, a recombinant form of human TPA. It's a second generation up to 100 milligrams the dose in 90 minutes based on weight. Low antigenicity and no allergic reactions, and it has high fibrin specificity and half-life of 4 to 8 minutes, and we can use it in acute MI and stroke. We have alteplase, RPA, recombinant form of smaller derivative of human RTPA. It's a second generation. The dose of 10 units, 2 doses, 30 minutes apart, each over 2 minutes. It has low antigenicity and no allergic reaction. It has high fibrin specificity and half-life of 14 to 18 minutes, and we can use it in acute MI also. Tenecteplase, genetically engineered. It's the third generation, dose of 30 to 50 milligrams based on weight. It has low antigenicity and no allergic reaction, but high fibrin specificity and half-life of 11 to 20 minutes. And it's uses in stroke and acute MI. Okay, transimic acid. Transimic acid is lysine analog antifibrinolytic agent. It binds to plasminogen, thereby inhibiting fibrinolysis. The indication include the prophylaxis to reduce bleeding and the use of blood products following cardiac surgery. Transimic acid is used also in following massive hemoptysis. The cautions include renal impairment, disseminating the vasodilation, and thromboembolic disease. The side effects of transimic acid include renal function and graft patency. The dose is 2 grams given IV at induction of general anesthesia, followed by 2 grams added to the prime volume of cardiopulmonary bypass circuit, and 1 gram at the termination of cardiopulmonary bypass. Okay, inotropes. Any question or comment?
Okay, just one comment
yes.
regarding the use of thrombolytics or thrombolytic therapy for valvular thrombosis.
Yes.
We usually say it's not recommended for left-sided valve thrombosis, can be used for right-sided valve thrombosis. However, in patients with acute thrombosis at the mitral or aortic, more on the mitral, that the thrombus is very small, we can give thrombolysis. But if the thrombus burden is high or it's more than 1 centimeter, it is not recommended to give any thrombolytic therapy to left-sided.
Yes, Dr. Lahman, thank you. Another question? Comment? Okay, inotropes. Okay, most inotropes works by increasing the intracellular cyclic adenosine monophosphate cyclic B levels, which occurs by stimulation of adenylate cyclase, which catalyzes the conversion of ATP to cyclic B, like dopamine, adrenaline, and noradrenaline, or the inhibition of phosphodiesterase enzyme, which normally convert the cyclic AMP to inactive 5-AMP. Like milrinone and enoximone. Also, cyclic AMP augments calcium influx into myocardial cells, thereby increasing contractility. Okay, here we have actions of different receptors and the actions of entropes on the receptor. Just to have an idea, we have alpha receptors. It causes vasoconstriction. Beta 1 increased contractility, entropy, and increased heart rate, increased conduction. Beta 2 it causes vasodilation, bronchodilation. We have the dopaminergic receptor. It causes coronary and renal and splanchnic vasodilation. The inotropes we have adrenaline. It works on alpha beta 1, beta 2, depending on the dose. So it can cause vasoconstriction, positive inotrope, or peripheral vasodilation, depending on the dose. We'll see in the next slide. Dopamine, the same thing. It works on alpha beta 1, beta 2 dopaminergic receptor, depending on the dose. Also, dopamine beta 2 and dopaminergic receptor. We have dobutamine. It's inodilator and isobriolene as well. It works on beta 1, beta 2. Noradrenaline. It's works on inopressor. It works on alpha and beta 1, also metaraminol, and we have phenylephrine. It action on alpha receptor and causes vasoconstriction. Okay, I will start with dopamine. The mechanism of action of dopamine is dopaminergic and adrenergic receptor agonist. The indication in a low cardiac output state, inotropic support following cardiac surgery or myocardial infarction. We should be cautious in tachyarrhythmia, pheochromocytoma, and patient on monoamine oxidase inhibitors. The side effects include tachycardia, hypertension, and peripheral vasoconstriction. The dose of dopamine acts on different receptors and has different effects. As we said, depend on the dose. Between 1 to 5 milligrams per kg per minute, dopaminergic receptors are activated, producing vasodilation of coronary, renal, and cerebral vasculature. If the dose between 5 to 10 milligrams per kg per minute, microgram. I'm sorry, doctor. Yes, microgram. If the dose between 5 to 10 microgram per kg per minute, dopamine activates beta 1 receptor, producing increased myocardial contractility and increased heart rate. At this dose, dopamine also has some beta 2 receptor agonist activity, producing peripheral vasodilation. If the dose above 10 microgram per kg per minute, dopamine mainly stimulates alpha adrenergic receptor, producing systemic vasoconstriction. Although this rise in systemic vascular resistance produces an increased blood pressure, it might be at the cost of increased myocardial oxygen demand, as the heart has to work in the face of the increased resistance. Dopamine, along with other inotropes, except dobutamine, must be delivered IV through a central vein to reduce the risk of peripheral vasoconstriction and subsequent scale necrosis. Okay, dobutamine. Dobutamine is a synthetic inodilator that activates beta 1 adrenergic receptors, positive inotropic effect, and also has beta 2 adrenergic action and causes vasodilation. The indication of dobutamine include inotropic support following cardiac surgery, myocardial infarction, and cardiogenic shock. Dobutamine is also used for stress echocardiography and magnetic resonance imaging. And the cautions include tachyarrhythmia, pheochromocytoma, and patients on monoamine oxidase inhibitors. The side effects of dobutamine include tachycardia and hypotension. The dose of 2.5 milligram per kg per minute, microgram. 2.5 to 10 microgram per kg per minute IV infusion. It can be given via peripheral line. Okay, isobriolene is a selective beta 1 and beta 2 adrenergic agonist, which produces positive inotropic and chronotropic and bronchodilatory effects. The indication of isobriolene is for bradycardia and responsive to atropine. The cautions include tachycardia, side effects of isobriolene, cardiac dysarrhythmia. The dose of 0.02 to 0.2 milligram per kg per minute IV microgram. Microgram per kg per minute IV infusion. Okay. Adrenaline. Now we'll talk about adrenaline. Adrenaline is a potent beta-1 adrenergic agonist producing increased myocardial contractility and increased heart rate. At low doses, adrenaline has beta-2 effects of systemic vasodilation and bronchodilation, but at higher doses, it is alpha adrenergic vasoconstriction effects predominate. Then the indication include bronchospasm, inotropic support, and cardiac arrest. The cautions include hypertension, pheochromocytoma, glaucoma, and diabetes. The side effects of adrenaline include tachycardia, arrhythmia, hypertension, and metabolic acidosis. Regarding the dose for cardiac arrest, it's 10 ml, 1 to 10,000 adrenaline, which is equated to 1 milligram. Inotropic support is 0.01 to 1 milligram per kg per minute IV. Okay, noradrenaline is a potent adrenergic agonist producing a systemic vasoconstriction, and beta-1 adrenergic agonist producing increased myocardial contractility and increased heart rate, means a positive inotropic and chronotropic effect. The indication include low cardiac output following cardiac surgery or myocardial infarction. Noradrenaline is particularly useful in conditions with low systemic vascular resistance, such as in sepsis or anaphylaxis. The cautions include hypertension and high systemic vascular resistance. Side effects of noradrenaline include hypertension, tachyarrhythmia, peripheral ischemia. The dose of 0.01 to 1 milligrams per kg per minute IV infusion. Okay. Phenylephrine, mechanism of action is a selective alpha.
All these drugs are microgram instead of milligram.
Even the phenylephrine?
Yes, yes.
Okay, microgram. Okay. Phenylephrine is a selective alpha-1 adrenergic receptor agonist with which produces systemic vasoconstriction. The indication include acute hypotension to maintain systemic blood pressure whilst on cardiopulmonary bypass. We should be cautious in severe hyperthyroidism. Side effects include hypertension, peripheral ischemia, and headache. The dose of 0.5 to 3 microgram per kg per minute IV infusion or 0.5 to 1 microgram IV policies whilst on cardiopulmonary bypass. Okay. Milrinone, class of drug is phosphodiesterase inhibitor. Mechanism of action: milrinone acts as inodilator. It reduces the systemic and pulmonary vascular resistance, as well as having moderate positive inotropic effects. The indication include low cardiac output state following cardiac surgery, especially in patients with presence of pulmonary hypertension or right ventricular failure. The cautions include hypertrophic cardiomyopathy and aortic stenosis. The side effects of milrinone include tachyarrhythmia, hypotension, and thrombocytopenia. The dose of milrinone is 0.125 to 0.75 microgram per kg per minute IV infusion. The addition, we should be aware, addition of alpha adrenergic agonists such as noradrenaline is often required to counteract the systemic vascular resistance, lowering probabilities of milrinone. Okay. Levosimendan. Levosimendan is a class of drugs known as calcium sensitizers. The molecule is a pyrazinone dinitrile derivative with additional action on adenosine triphosphate sensitive potassium channels. Levosimendan also causes coronary and systemic vasodilation. In addition to sensitizing troponin to intracellular calcium, levosimendan inhibits phosphodiesterase 3 and open ATP-sensitive potassium channels, which might produce vasodilation. Okay. Levosimendan is used IV for treating decompensated heart failure because it increases contractility and produces anti-stunning effects without increasing myocardial calcium concentration or prolonging myocardial relaxation. In patients with heart failure, IV levosimendan reduce worsening heart failure or death significantly. IV levosimendan significantly also increase cardiac output and decrease filling pressure and decompensated heart failure in large double-blind randomized trials and after cardiac surgery in smaller trials. Levosimendan is well tolerated without any arrhythmogenicity. Unlike currently available inotropes, levosimendan does not increase myocardial oxygen use and has been used effectively in beta-blocked patients. Levosimendan also does not impair left ventricular relaxation. Clinical studies have demonstrated short-term hemodynamic benefits of levosimendan over both placebo and dobutamine. A large scale long-term morbidity and mortality data are insufficient, but the levosimendan infusion versus dobutamine in severe low outward heart failure study suggested a mortality benefit of levosimendan over dobutamine. The side effects include headache and hypotension, and the usual dosage of IV levosimendan used in clinical trials of patients with heart failure is 6 to 12 microgram per kg loading dose over 10 minutes, followed by 0.05 to 0.2 microgram per kg per minute as continuous infusion. Hemodynamic responses are generally observed within 5 minutes of commencement of infusion of the loading dose. The peak effects are observed within 10 to 30 minutes of infusion. The duration of action of levosimendan is about 1 to 2 hours. No dose adjustment are required in patients with mild to moderate renal failure. Similarly, loading doses do not require adjustment in a patient with a mild to moderate hepatic impairment. Okay. Now we have statins and hyperlipidemia. Any question or comment before proceed?
Just a couple comments. The nomenclature, adrenaline and epinephrine, norepinephrine, noradrenaline, they're synonymous. It's the same thing. So I think European use more noradrenaline and adrenaline, and European and North America, they use epinephrine, norepinephrine. So, and the other thing is that norepinephrine beta-2 action is really offset by the strong alpha-1 agonist. So we don't see any vasodilation with norepinephrine. On the contrary, it's all vasoconstriction, and that's the main use for norepinephrine, to increase the blood pressure. That's basically norepinephrine. Its effect on the beta-1 and beta-2 is much less than dobutamine or dopamine or other inotropes. And we use it actually sometimes in patients who have tachycardia with low blood pressure, because it does not increase the heart rate much. And levosimendan, there is 2 clinical trials shows no difference than dobutamine. So in North America, it's not approved. It's only approved in Europe. So it doesn't offer that much advantage over dobutamine. That's what I have.
Yes, thank you, Dr. Naman. Okay, statins. I will start by just an overview of hyperlipidemia. Hyperlipidemia is considered one of the major risk factors causing cardiovascular diseases, and cardiovascular disease is the leading cause of death worldwide. Hyperlipidemia is an increase in one or more of the plasma lipids. Hypercholesterolemia and hypertriglyceridemia are the main causes of atherosclerosis, which is strongly related to cardiovascular diseases. Atherosclerosis is a slow, complex process of arteries hardening due to a deposition of flakes of cholesterol in the arterial wall, leading to narrowing of the arteries. Atherosclerosis and atherosclerosis-associated disorders like coronary, cerebrovascular, peripheral vascular diseases are accelerated by the presence of hyperlipidemia. Plaque initially begins to build up where the arteries are damaged, and it hardens over time. As a result, an area of plaque can rupture and initiate clotting cascade. Other risk factors for cardiovascular diseases include cigarette smoking, hypertension, obesity, diabetes, chronic kidney disease, and advanced age. Hyperlipidemia may be due to lifestyle factors, for example, lack of exercise or diet containing excess of saturated fats. Hyperlipidemia also result from an inherited defect in lipoprotein metabolism and or from a combination of both genetic and lifestyle factors. Appropriate lifestyle changes along with drug therapy can lead to a 30 to 40% reduction in cardiovascular disease mortality. Okay, this is just a table of lipid profile. It just shows normal figures of different parameters of lipid profile. We have cholesterol. The optimal parameter is 150 milligram per deciliter. LDL below 100. Triglyceride also below 100. HDL should be more than 60 as optimal. But in the normal ranges, cholesterol is below 200 milligram per deciliter. LDL between 100 and to 129 milligram per deciliters, and triglyceride 101 to 150, and HDL 60. Borderline cholesterol between 200 and 239. Regarding LDL between 130 159, triglyceride with between 150 159, and HDL between 40 and 60. Considered high cholesterol if it is above 240, LDL between 160 and 189, and triglyceride between 499, and HDL below 50. Very high if LDL is above 190 milligram per deciliter, and triglyceride above 500, and if HDL below 35. Okay, statins. Statins is 3-hydroxy 3-methyl-glutaraldehyde coenzyme reductase inhibitors. Statins competitively inhibit the hepatic 3-hydroxy 3-methyl-glutaraldehyde reductase, which is involved in cholesterol synthesis. The indication include prophylaxis and therapeutic lowering of serum cholesterol, primary and secondary prevention of cardiovascular events. The cautions include hepatic impairment and pregnancy. The side effects include myalgia, rhabdomyolysis, hepatic dysfunction, nausea, vomiting, and abdominal pain. The dose of simvastatin, bravastatin, fluvastatin, or atorvastatin is between 10 to 80 milligrams OD. And here we have just a summary of the different characteristics of statins. So we have regarding the reduction of serum LDL, we have rosuvastatin is nearly 60% in the reduction of serum LDL, and atorvastatin is 55%. And regarding the reduction of serum triglyceride, we have atorvastatin is 29, and rosuvastatin is 18, bravastatin 24. And reduction of serum, increasing serum HDL, we have bravastatin of 12% and rosuvastatin 8, atorvastatin 6. Half-life of atorvastatin is 14 hours, and rosuvastatin 19 hours. And regarding the maturation of nervous system, central nervous system, we have simvastatin, pitavastatin, and lovastatin can deteriorate the CNS. and renal excretion of absorbed dose, rosuvastatin of 10% and atorvastatin of just 2%. Okay. And here we have just various classes of anti-hyperlipidemic regarding the dose, effect on lipids, and side effects. We have first the bile acid binding resins like cholestyramine or cholestyramine. Cholestyramine, it's between 4 to 16 milligrams, and the cholestyramine between 5 to 30 milligrams. Triglyceride not affected. It will decrease the LDL and increase the HDL. About the side effects, the patient, it's more patient tolerance due to GI disturbance. It causes constipation, nausea, and indigestion, bloating, and fluctuance. On long-term therapy, osteoporosis due to calcium loss, hypertriglyceridemia, and deficiency of vitamin and minerals. We have also fibric acid derivative, gemfibrozil, bezafibrate, and fenofibrate. Regarding the dose, it's 1,200 milligrams for gemfibrozil and 600 milligrams for bezafibrate and 200 milligrams for fenofibrate. All of them decreases the triglyceride, decrease the LDL, and decrease the HDL. These agents are usually well tolerated, but can cause gastrointestinal symptoms, myopathy, arrhythmia, skin rashes, and gallstones. We should avoid in patients with liver and renal dysfunction. We have also nicotinic acid derivative, niacin, the dose between 2 to 4 grams, decreases the triglyceride, decreases the LDL, and increases the HDL. It is also a poor patient tolerance, intense cutaneous flush, itching, headache, nausea, and abdominal discomfort, elevation of the liver enzymes, glucose intolerance, and hyperuricemia. Combination with statins increase the incidence of rhabdomyolysis. Lastly, we have cholesterol absorption inhibitors. We have ezetimibe, the dose of 10 milligrams. It decreases LDL, decreases cholesterol. The drug is usually well tolerated. Headache, abdominal pain, and diarrhea, elevation in the liver enzyme, alanine, and aspartate transaminase could be as a side effects. Okay. Any comments or question about statins and hyperlipidemia, anti-hyperlipidemic agent?
Just a quick comment.
Of course.
The LDL is the target for therapy,
Yes.
and it's the part of the LDL which is responsible for most of the atherosclerotic, cardiovascular, and cerebral diseases. So the target of treatment is the LDL. Usually we don't target treatment for triglyceride except if it's very, very high, because it causes actually more pancreatitis before it causes atherosclerosis. So that's the only thing. And
yes,
all patients with atherosclerotic cardio or cerebral or peripheral vascular disease should be on high dose, high intensity to bring the LDL at least 50%. And if that's not reached, then you add the non-statin. And the first drug to add is ezetimibe, which is the cholesterol absorption inhibitor. And finally, the PCSK9 inhibitors. So
yes,
that's all.
Thank you, Dr. Nan. Yeah, thank you, Dr. Nan. Okay, beta blockers. Beta blockers bind to beta adrenoreceptors to produce negative inotropic and chronotropic effects, thereby reducing myocardial oxygen demand. Beta blockers also have cardiomyocyte stabilizing effect, thereby acting as anti-arrhythmic agent, as we will see in the next slides. The indication include angina, hypertension, myocardial infarction, supraventricular tachycardia, primary and secondary prevention of cardiovascular events, and heart failure. We should be cautioned in patient with asthma, peripheral vascular disease, diabetes, poor left ventricular function, and heart block. The side effects include postural hypotension, bradycardia, heart block, and peripheral vascular vasoconstriction and bronchospasm. The dose of bisoprolol is 1.25 to 10 milligrams OD, atenolol of 25 to 100 milligrams OD, metoprolol between 25 to 100 milligrams BID or TID, carvedilol of 3.125 to 50 milligrams OD or BID. We have cardioselective beta blockers such as bisoprolol can be trialed in patients with mild asthma, peripheral vascular disease, or even in diabetes. And certain beta blockers have also been shown to be effective in heart failure, such as carvedilol, bisoprolol, and metoprolol. Okay. Labetalol selectively antagonizes alpha 1, beta 1, and beta 2 adrenergic receptor, thereby reducing the absolute blood pressure and shear stress forces within the aorta. The indication include blood pressure control in patients with acute aortic dissection. The cautions include heart block. Side effects of labetalol include hypotension and bradycardia. The dose of 15 milligrams per hour increased to 120 milligrams per hour depending on the blood pressure. Okay, calcium channel blockers. Calcium channel blockers inhibit the calcium influx during phase 2 of the cardiac action potential plateau phase, thereby reducing cardiac contractility and the propagation of the cardiac electrical impulses. Calcium channel blockers also relaxes vascular smooth muscle, thereby dilating coronary and peripheral arteries. The indication include angina, hypertension, supraventricular tachycardia, pulmonary hypertension. Cautions include poor left ventricular function, heart failure, heart block, and severe aortic stenosis. The side effects of calcium channel blockers include flushing, headache, peripheral edema, heart block, and bradycardia. The dose of amlodipine is 5 to 10 milligrams OD, diltiazem 60 to 120 milligrams TID, or slow release preparation of 120 to 360 milligrams OD. Nifedipine between 5 to 20 milligrams TID, or slow release of 20 to 60 milligrams OD. Verapamil of 40 to 120 milligrams TID, or slow release of 240 and 480 milligrams OD. Okay, we have here a table between the calcium channel blockers, dihydropyridines and non-dihydropyridines. First, we have dihydropyridines, amlodipine and felodipine. They are long-acting only, and nifedipine is short-acting. It uses in elderly patient isolated systolic hypertension, angina, peripheral vascular disease, Raynaud's phenomena, carotid atherosclerosis, pregnancy, black hypertensive. Their advantages is no metabolic disturbance, no change in blood glucose, potassium, uric acid, lipid, no metabolic disturbance, may improve renal function, maintain optimal physical, mental, and sexual activities. The contraindication include tachyarrhythmia, heart failure, and antiretroviral therapy. And side effects, as we mentioned, edema of the ankles, flushing, headache, gingival hypertrophy, constipation, tolerance might develop to headache. For the edema, a diuretic might be needed. And regarding the calcium channel blockers, non-dihydropyridines, verapamil and diltiazem, we can use it in angina, carotid atherosclerosis, supraventricular tachycardia. Short-acting drug should be combined with beta blockers in the coronary artery disease and should be avoided in stroke and hypertensive crisis.
the contraindication could be in the AV block grade 2 and 3 and heart failure. The possible contraindication, constipation for the verapamil and antiretroviral therapy. The side effects could be constipation regarding the verapamil, cardiac conduction defects, worsening of systolic function, and gingival hyperplasia. And here is the note: nifedipine is not recommended as it drops blood pressure quickly and may increase the risk of stroke and MI. So it is not recommended regarding the nifedipine. Okay. Now ACEs, inhibitors, and angiotensin receptor blockers.
If I may,
yes.
Paris.
Yes.
Just about the calcium channel blockers.
Of course.
Nifedipine immediate release is no longer used and it's no longer available. And should not be used at all, like you said. Only long-acting can be used. Now, the use of non-dihydropyridine with the beta blocker, very rare situation you need to use both. Now, for hypertension, you can use the dihydropyridine with beta blocker if needed. And you know, the beta blocker are not used alone, or they're not recommended for hypertension alone, unless the patient has a compelling indication like heart failure or coronary artery disease or arrhythmia. So these are the comments I want to say.
Okay, thank you, Dr. Na'im. Okay, just before before I talk about those drugs, I want just to go through an overview about the renin-angiotensin system. The renal juxtaglomerular apparatus releases renin in response to an acute reduction in the plasma volume or mean arterial pressure. Renin converts the circulating angiotensinogen, which is produced in the liver, into inactive angiotensin 1. Angiotensin 1 is cleaved into active angiotensin 2 by converting enzyme, which is produced in the pulmonary and renal endothelium. Angiotensin 2 results in restoration of plasma volume and blood pressure by stimulating arterial vasoconstriction, aldosterone release from the adrenal cortex, resulting in sodium and water reabsorption and potassium secretion at the renal distal convoluted tubules. And also antidiuretic hormone released from the posterior lobe of the pituitary gland, resulting in water and reabsorption at the renal collecting ducts, and finally thirst via hypothalamic receptors. Both angiotensin 2 and aldosterone negatively feedback on juxtaglomerular apparatus and renin release. Okay, angiotensin converting enzyme inhibitors inhibit the conversion of inactive angiotensin 1 to active angiotensin 2, thereby reducing the vasoconstrictive effect of angiotensin 2 and reducing the release of aldosterone by the adrenal cortex. The indication include hypertension, liver, left ventricular systolic dysfunction, secondary prevention of cardiovascular events. Cautions include renal impairment, renal artery stenosis, and aortic stenosis. Side effects include hypersensitivity, hypotension, chronic cough, hyperkalemia, and angioedema. The dose of ramipril is between 125 to 10 milligrams OD, prednisolone 2 to 8 milligrams OD, lisinopril between 2.5 to 40 milligrams OD, enalapril between 5 to 20 milligrams OD or BID, captopril between 6.25 to 50 BID. Okay, angiotensin receptor blockers have similar properties to ACEs inhibitors, but unlike ACEs inhibitors, angiotensin receptor blockers do not break down bradykinin, which is thought to be the reason for the persistent cough associated with ACEs inhibitors. The indication include hypertension and left ventricular systolic dysfunction when ACEs inhibitors are not tolerated by the patient, or when the patient is on maximum dose of ACEs inhibitors. Angiotensin receptor blockers can be used together with the ACEs inhibitors. Okay. Cautions include renal artery stenosis, renal impairment, aortic stenosis, hypertrophic cardiomyopathy. Side effects include hyperkalemia and hypotension. The dose we have Cansartan, it's between 4 to 32 milligrams OD, Losartan between 25 to 100 milligrams OD. Okay, nitrates. Nitrates are small. Okay,
one
of course.
comment.
Yes.
ACE inhibitor and ARBs are in most indication are not supposed to be combined. There is very little benefit, if any, and there is more complication like renal impairment, hyperkalemia. So it's not recommended to be used, and actually the guideline, they should not be combined, yes. And there is the new class, which is called ARNI, angiotensin receptor neprilysin inhibitors. The drug name is Entresto, which is valsartan plus sacubitril, which is now superior in terms of management of heart failure with reduced ejection fraction. So this is a new class of medication that is superior than ACE inhibitor in management of heart failure, reduced ejection fraction, which improves the outcome, mortality, and hospitalization. So if you encounter that drug, is very good drug. Thank you.
Yes, thank you, Dr. Mo. Okay. Nitrates. Nitrates are a smooth muscle relaxant that results in coronary vasodilation and reduce coronary spasm. It reduces the preload and afterload, thereby reducing myocardial oxygen demand. The indication include angina, left ventricular failure. Cautions include the hypertrophic cardiomyopathy, aortic stenosis, glaucoma, and hypovolemia. The side effects include postural hypotension, tachycardia, headaches, flushing, and palpitations, and methemoglobinemia. Okay, regarding the dose, glyceryl trinitrate infusion of 10 to 200 milligrams per minute. Glyceryl trinitrate sublingual tablet or spray, 0.3 to 0.5 milligrams BRN. Isosorbide mononitrate between 10 to 60 BID, or slow release of 30 to 120 milligrams OD. Okay, sodium nitroprusside. Sodium nitroprusside relaxes arterial smooth muscle, thereby reducing systemic and pulmonary afterload. The indication include refractory hypertension following aortic dissection or post cardiac surgery and pulmonary hypertension. The cautions include hepatic dysfunction and also the syringe that used to infuse sodium nitroprusside needs to be wrapped in aluminum foil to protect it from the light. The side effects of reflex tachycardia, headache, dizziness, cyanotoxicity. The dose of sodium nitroprusside include 0.5 to 8 microgram per kg per minute for a maximum of 48 hours. Okay, diuretics. Any comments or questions? Okay.
Nothing from me.
Okay, thank you, doctor. Okay, I will just go through an overview also. Diuretics are the drugs that increases the volume of urine excreted. Most diuretics agents are inhibitors of renal ion transporters that decreases the reabsorption of sodium at different sites in the nephron. As a result, sodium and other ions enter the urine in a greater than normal amount, along with water, which is carried massively to maintain osmotic equilibrium. Diuretics thus increase the volume of urine and often change its pH, as well as the ionic composition of the urine and blood. So the diuretic effect of the different classes of diuretics varies accordingly with the site of action. In addition, the ion transport inhibitors, other types of diuretics include osmotic, osmotic diuretics, aldosterone antagonists. While diuretics are most commonly used for management of excessive fluid retention, many agents within this class are prescribed for non-diuretic indication or for systemic effects in addition to their action on the kidney. Include use of thiazide in hypertension and use of aldosterone antagonists in heart failure. Okay, we have this figure. The kidney regulates the ionic composition of volume of urine by active reabsorption or secretion of ions and passive reabsorption of water at 5 functional zone along the nephron. First, we have the proximal convoluted tubule, the site of action for carbonic anhydrase inhibitor. It has a weak diuretic action. It's also for osmotic diuretic as well, but it is rarely used for diuresis. Secondly, we have the descending lobe Hilli site of action for osmotic diuretics. Third, we have the ascending lobe of Hilli for lobe diuretics. It is the strongest diuretic action. Fourth, we have the distal convoluted tubules for thiazide. It's weak diuretic action. Fifth, we have the collecting tubule and duct for aldosterone antagonist, weak to moderate action depending on the dose. Epithelial sodium channel antagonist, weakest diuretic action, and vasopressin 2 agonist, moderate aquaphoresis action. Okay, thiazides. Thiazide diuretics inhibit sodium reabsorption at the distal convoluted tubule, as we just saw. Indication include hypertension, peripheral edema. Cautions include the nephrotic syndrome and hyperaldosteronism. Side effects: postural hypotension, hypokalemia, hyponatremia, and gout. We have the dose of thiazide, hydrochlorothiazides of 6.25 to 50 milligrams daily, and metadazole 2.5 to 20 milligrams per day. Okay. We have lobe diuretics. Lobe diuretics inhibit water and electrolyte reabsorption from the ascending limb of the lobe of Henle. Indication include pulmonary edema, heart failure, hyperkalemia, peripheral edema, and oliguria associated with renal impairment. The cautions include hypovolemia and renal failure. Side effects include hypokalemia, gout, hyponatremia, and deafness. The dose of furosemide is 10 to 80 milligrams OD or BID or IV infusion at a rate of 2 to 10 milligrams per hour. Bometanide 1 to 5 milligrams OD or BID or IV. Okay, mannitol. Mannitol is osmotic diuretic and a weak renal vasodilator. Indication: cerebral edema, fluid overload associated with cardiopulmonary bypass. Caution: we should be cautious in congestive heart failure. The side effects include fever. Dose of 0.5 gram per kg given as bolus with the cardiopulmonary bypass circuit prime volume. Okay. Amiloride. Amiloride is potassium-sparing diuretic. Amiloride blocks sodium reabsorption at the distal convoluted tubule and collecting ducts, thereby promoting the loss of sodium, water whilst preserving potassium. Indication include diuresis with potassium conservation. The cautions include potassium supplementation and concurrent ACEs inhibitor administration for the risk of hyperkalemia. The side effects include hyperkalemia, hyponatremia, and postural hypotension. The dose of 5 to 10 milligrams OD. Spironolactone is aldosterone antagonist. Spironolactone inhibits the action of aldosterone at the distal convoluted tubule, thereby promoting the loss of sodium and water whilst preserving potassium also. Indication include edema and ascites caused by cardiac failure, hepatic cirrhosis, nephrotic syndrome, or Crohn syndrome. The cautions include potassium supplementation, concurrent ACEs inhibitor administration, and Addison's disease. Side effects include hyperkalemia, hyponatremia, postural hypotension, and gynecomastia. Dose of 25 to 400 milligrams OD. Okay, the last part of the lecture, arrhythmia. Any comment or question before proceed?
Go ahead.
Okay, thank you. Okay, this is the last part of my lecture. Arrhythmia are caused by abnormalities in impulse formation and conduction in the myocardium. Arrhythmia present as a complex family of disorders with varieties of symptoms. To make sense of this large group of disorders, it is useful to organize the arrhythmia into groups according to anatomic site of the abnormality, atria, IV node, or the ventricles. Okay. Regarding the causes of arrhythmia, most arrhythmias arise either from aberration in impulse generation or abnormal automaticity, or from a defect in impulse conduction. Okay, first we have the abnormal automaticity. Normally, the SA node shows a faster rate of discharge than other pacemaker cells, and thus it normally sets the pace of contraction for the myocardium. So, if a cardiac site other than the SA node shows enhanced automaticity, they might generate competing stimuli, and arrhythmia then may arise. Most of anti-arrhythmic agents suppresses automaticity by blocking either sodium, calcium, or calcium channels to reduce the ratio of these ions to potassium channels. And this decreases the slope of phase 4 depolarization and raises the threshold of discharge to a less negative voltage, leading to an overall decrease in frequency of discharging. This effect is more pronounced in cells with ectopic pacemaker activity than in normal cells. Okay, the other cause is abnormalities in impulse conduction. Impulses from higher pacemaker center are normally conducted down pathway that bifurcate to activate the entire ventricular surface, as we can see here in this figure in A. A phenomena called re-entry can occur in if a unidirectional block caused by myocardial injury or prolonged refractory period results in abnormal conduction pathway, as we also we can here see it in B. Re-entry is the most common cause of arrhythmia, and it can occur at any level of the cardiac conduction system. This short circuit pathway results in re-excitation of cardiac muscle, causing premature contraction or sustained arrhythmia. Anti-arrhythmic agents prevent re-entry by slowing conduction like class 1 drugs, or increasing the refractory period like class 3 drugs, thereby converting a unidirectional block into bidirectional block. Okay. Class 1 anti-arrhythmic drugs. Class 1 anti-arrhythmic drugs act by blocking voltage-sensitive sodium channels. They bind more rapidly to open or inactivated sodium channels than to channels that are fully repolarized. Therefore, these drugs shows a greater degree of blockade in tissue that are frequently depolarizing. This property is called use dependence, and it is enables these drugs to block cells that are discharging at abnormally high frequency without interfering with the normal beating of the heart. The use of sodium, channel blockers has declined due to their pro-arrhythmic effect, particularly in patients with reduced left ventricular function and atherosclerotic heart disease. Class 1 drugs are further subdivided into 3 groups according to their effect on duration on the cardiac action potential. We have intermediate class A1, fast AB, 1B, 1A, 1B fast, and slow 1C blockers with the sodium channel blocker. Okay, class 1A, we have quinidine, brocanamide, and disopiramide. Quinidine is a prototype of class 1A drug. Other agents in this class include brocanamide and disopiramide. Because of their concomitant class 3 activity, they can participate arrhythmia that can progress to VFib. Okay, the mechanism of action include quinidine binds to open and inactivated sodium channels and prevents sodium influx, thus slowing the rapid upstroke during phase 0. It also decreases the slope of phase 4, spontaneous depolarization, inhibits potassium channel and blocks calcium channels. Because of this action, it slows conduction velocity and increases refractoriness. Quinidine also has a mild alpha adrenergic blocking and anticholinergic action. Although procainamide and pyrimide have a similar action to those of quinidine, there are less anticholinergic activity with procainamide and more with disopiramide. Neither procainamide nor disopiramide has alpha blocking activity. Disopiramide produces a greater negative inotropic effect, and unlike the other drugs, it causes peripheral vasoconstriction. Okay, therapeutic use of quinidine, though effective in treatment of a wide variety of arrhythmia, including atrial AV junctional and V ventricular tachyarrhythmia, it used rarely due to its adverse effect. Procainamide, it's only available in IV formulation and may use to treat acute atrial and ventricular arrhythmia. However, electrical cardioversion and defibrillation and amiodarone have mostly replaced procainamide in clinical practice. Disopiramide is used vaguely in vaguely mediated atrial fibrillation and in hypertrophic obstructive cardiomyopathy. It can be used as an alternative treatment of ventricular arrhythmia. Here we have a table of the dose, pharmacokinetics, side effects, and interactions of quinidine and disopiramide. The dose of quinidine oral as sulfate 600 milligrams, 3 times a day, gluconate 3 times a day, and gluconate, quinidine gluconate 324 to 648 milligrams every 8 hours. Reduced dose for renal failure. Pharmacokinetics of quinidine will absorbs orally 80% protein bound, extensive hepatic metabolism, CYB 3A4 70% to 3-hydroxyquinidine, and renal 30%. Non-cardiac toxicity or side effects include diarrhea, thrombocytopenia, synconism, pruritus, and rash. Cardiac side effects include QRS prolongation with toxic doses, torsade de points, not dose related or dependent, hypotension, and tachycardia. Drug interactions include inhibit CYP2D6 by increased concentration of drugs metabolized by this enzyme. For example, it increases the effect of tricyclic antidepressants as haloperidol, some beta blockers, fluoxetine, and narcotics. Increased digoxin and amiodarone levels. It causes cardiac depression with beta blockers. Quinidine metabolism is increased by phenobarbital, phenytoin, and rifampicin. Disopiramide, the dose oral between 100 and 400 milligram every 8 to 12 hours, maximal dose of 800 milligram per 24 hours. Reduced dose for renal or hepatic dysfunction. Pharmacokinetics, renal antihepatic CYB 3A4. Non-cardiac side effects include anticholinergic side effects, contraindication for narrow angle glaucoma, dry mouth, urinary retention, constipation, blurring of vision. Cardiac side effects include congestive heart failure exacerbation, torsade de points, and there are no significant interaction regarding this pyramide. Okay, class 1B. The class 1B agent lidocaine and mixidipine rapidly associate and dissociate from sodium channels. Thus, the actions are greater when the cardiac cell is depolarized or firing rapidly. The class drugs lidocaine and mixidipine are useful in treating ventricular arrhythmia. In addition to sodium channel blockade, lidocaine and mixidipine shortens phase 3 repolarization and decreases the duration of the action mutation. Neither drug contributes to negative inotropy. It can be used ventricular fibrillation or ventricular tachycardia, IV lidocaine can be used, and lidocaine may also be used in combination with amiodarone for ventricular tachycardia storm. The drug does not markedly slow conduction and thus has a little effect on atrial and or AV junction arrhythmia. Mixdilitine is used for orally chronic treatment of ventricular arrhythmia, often in combination with amiodarone. Okay. Also, we have the table here for the dose and the pharmacokinetics, cardiac and non-cardiac side effects interaction. Lidocaine, the dose of 50 to 100 milligram bolus, followed by 20 to 40 milligrams every 10 to 20 minutes IV. Regarding pharmacokinetics, inactive orally, IV route, rapid onset, a short duration of action, high first pass metabolism. Metabolism depends on the hepatic flow, half-life of 8 minutes, elimination, half-life of 2 hours. Non-cardiac toxicity include CNS symptoms, nystagmus, an early indicator for toxicity, drowsiness, slurred speech, paresthesia, agitation, confusion, and convulsions. Cardiac lidocaine is the least cardiac toxic. The interaction with propanol decreases the half-life of lidocaine. Mixdilitine, it's oral analog of lidocaine. No first pass metabolism regarding its pharmacokinetics. Non-cardiac toxicity include nausea, vomiting, dyspepsia, tremors, and tremors early sign of toxicity, nystagmus, and dizziness. Cardiac side effects include hypotension, bradycardia, widened QRS. Okay. Class 1C antiarrhythmic flecainide and propafenone. These drugs slowly dissociate from resting sodium channels and show prominent effects at normal heart rates. Due to their negative inotropic and pro-arrhythmic effects, uses of these agents is avoided in patients with structural heart disease, like left ventricular hypertrophy, heart failure, atherosclerotic heart disease. Okay. Flecainide suppresses the phase 0 upstroke in Purkinje and myocardial fibers. This causes marked slowing of conduction in all cardiac tissue, with a minor effect on the duration of the action potential and refractoriness. Automaticity is reduced by increase in the threshold of potential rather than a decrease in the slope of phase 4 depolarization. Flecainide also blocks potassium channel, leading to increased duration of the action potential. Propafenone, like flecainide, slows the conduction in all cardiac tissue but does not block potassium channel. It possesses weak beta blocking properties. Okay. The class 1C drug flecainide is commonly used to maintain sinus rhythm in atrial fibrillation patients. It is useful in the maintenance of sinus rhythm in atrial flutter or fibrillation in patients without structural heart disease and in treating refractory ventricular arrhythmia. Significant coronary artery disease and any structural heart disease are a contraindication to the use of flecainide and propafenone, as it increases the risk of proarrhythmia and sudden cardiac death. These agents must be used in combination with an AV blocking agent in order to prevent rapid atrial fibrillation or atrial flutter conduction through the AV node, resulting in a very fast ventricular race if a breakthrough episode occurs, since class 1C drugs also act to increase AV nodal conduction. Also, flecainide can be used as needed basis in the outpatient setting. Use of propafenone is restricted mostly to atrial arrhythmias, like rhythm control of atrial fibrillation or flutter, and paroxysmal supraventricular tachycardia. Prophylaxis in patients with IV re-entry tachycardias. Okay. Also, we have the dose of pharmacokinetics, non-cardiac, cardiac toxicity, and interaction of flecainide and propafenone. The flecainide is a reserved drug for ventricular arrhythmia. The dose of 50 to 100 milligram twice a day, maximum dose of 300 to 500 milligram per day. Renal and variable hepatic metabolism, CYP2D 2d6 in pharmacokinetics. And then cardiac toxicity include dizziness, headache, blurring of vision, and cardiac toxicity include risk of sudden cardiac arrest, atrial flutter with a 1-to-1 conduction, ventricular tachycardia, contraindicated with coronary disease, as we mentioned before. The interaction we should use it with caution. With potent inhibitors of CYP2D6 may decrease the metabolism of warfarin, increase digoxin levels, flecainide levels are increased by amiodarone. Regarding bromophenone, the dose in oral 100 to 300 milligrams every 8 hours of sustained release, 225 to 425 milligrams twice a day. Hepatic metabolism CYP2D6 in pharmacokinetics. Then cardiac side effects, metallic taste, dizziness. Cardiac side effects include atrial flutter with 1-to-1 conduction, ventricular tachycardia, contraindication with coronary disease. The interaction may decrease the metabolism of warfarin, increase the digoxin levels. We should use it in caution with potent inhibitors of CYP2D6. Okay. Class 2 drugs. Class 2 drugs are agents are beta adrenergic antagonists or beta blockers. These drugs diminish phase 4 depolarization and thus depresses automaticity, prolongs AV conduction, and decreases heart rate and contractility. First, we have metoprolol. Metoprolol is the most widely used beta blocker for the treatment of cardiac arrhythmia. Compared to non-selective beta blockers such as propranolol, it reduces the risk of bronchospasm. It is extensively metabolized by CYP2D6. It has CNS maturation less than propranolol but more than atenolol. Then we have esmolol. Esmolol is a very short and fast-acting beta blocker used for IV administration in acute arrhythmia that occur during surgery or emergency situation. Osmolol is rapidly metabolized by esterases in red blood cells. As such, there is no pharmacokinetics drug interaction for osmolol. Propranolol and nadolol are drugs of choice for long QT syndrome. And common adverse effects with beta blockers include bradycardia, hypotension, and fatigue. Therapeutic use include class 2 agents are useful in treating tachyarrhythmia caused by increased sympathetic activity. They are also used for atrial flutter, fibrillation, and for AV nodal re-entry tachycardia. In addition, beta blockers prevent life-threatening ventricular arrhythmia following myocardial infarction. Also, I have the table for the dose of difference between metoprolol and esmolol. The dose of metoprolol is the 2.5 to 5 milligram bolus over 2 minutes, up to 3 doses. As oral, 25 to 100 milligram twice daily. May use metoprolol 6-8. In ER, we use 25 to 200 milligram daily. It has extensive hepatic metabolism by CYP2D6 and CNS maturation. Non-cardiac side effects include dizziness, headache, tiredness, depression, diarrhea, pruritus, rash, dyspnea, cold extremities, constipation, dyspepsia. Cardiac side effects include bradycardia, heart failure, hypotension. CYP2D6 poor metabolism may have 5-fold higher risk for developing adverse effects. Regarding esmolol in IV for acute arrhythmia in emergency situation or during surgery, 500 microgram per kg over 1 minute. Maintenance of 50 to 200 microgram per kg per minute. It is a very short elimination half-life, 9 minutes, metabolized by RBC esterases. Non-cardiac, it has no non-cardiac side effects, well tolerated. And regarding the cardiac side effects, generally tolerated well, but is associated with increased risk of hypotension that is rapidly reversible. No pharmacokinetics drug interaction with esmolol, but should be used with caution in patients on beta blocker therapy. Bradycardia patient and patient with decompensated heart failure. Okay, class 3 drugs, antiarrhythmic drugs. The class 3 agents block potassium channel and thus diminish the outward potassium current during repolarization of cardiac cells. These agents prolong the duration of the action potential without the altering phase 0 of depolarization or the resting membrane potential. Instead, they prolong the effective refractory period, increasing refractoriness. All class 3 drugs have the potential to induce arrhythmia. Okay, first we have amiodarone. Amiodarone contains iodine and it is related structurally to thyroxine. It has complex effects showing class 1, 2, 3, 4, and 4 actions, as well as blocking activity. Its dominant effect is prolongation of the action potential duration and the refractory period by blocking potassium channels. We can use amiodarone, has been primary mainstay of therapy for the rhythm management of atrial fibrillation or flutter. Amiodarone is effective in the treatment of severe refractory supraventricular and ventricular tachyarrhythmias. Despite its adverse effect profile, amiodarone is thought to be the least pro-arrhythmic of the class 1 and 3 anti-arrhythmic drugs. Okay, I have now dronedarone, sotalol, dofetilide, and ibutilide. Okay, dronedarone is benzofuranamidarone, a derivative which is less lipophilic and has a shorter half-life than amiodarone. It does not have the iodine moieties that are responsible for thyroid dysfunction associated with amiodarone. Like amiodarone, it has class 1, 2, 3, and 4 actions. Dronedarone has a better adverse effect profile than amiodarone, but it may still cause liver failure. The drug is contraindicated in those with symptomatic heart failure or permanent atrial fibrillation due to increased risk of death. Currently, dronedarone is used to maintain sinus rhythm in atrial fibrillation or flutter, but it is less effective than amiodarone. Okay, sotalol, although a class 3 antiarrhythmic drug agent, it also has non-selective beta blocker activity. The levatory isomer L-sotalol has beta blocking activity, and the sotalol has a class 3 antiarrhythmic action. Sotalol blocks a rapid outward potassium current known as the delayed rectifier current. This blockade prolongs both repolarization and duration of the action potential, thus lengthening of the effective refractory period. Sotalol is used for maintenance of sinus rhythm in patients with atrial fibrillation, atrial flutter, or refractory paroxysmal supraventricular tachycardia, and in the treatment of ventricular arrhythmia. Since sotalol has blocking properties, it is commonly used for these indication and patients with left ventricular hypertrophy or atherosclerotic heart diseases. This drug can cause the typical adverse effect of associated with beta blocker, but has a low rate of adverse effect when compared to other anti-arrhythmic agents. The dosing interval should be extended in patients with renal disease, since the drug is renal eliminated. To reduce the risk of pro-arrhythmic effects, sotalol should be initiated in hospital to monitor QT interval. Okay, dofetilide. Dofetilide is a pure potassium channel blocker. It can be used as a first-line anti-arrhythmic agent in patients with persistent atrial fibrillation and heart failure, or in those who have coronary artery disease. Because of the risk of pro-arrhythmia, dofetilide initiation is limited to the inpatient setting. The half-life of this oral drug is 10 hours. The drug is mainly excreted and changed in urine. Drugs that inhibit active tubular secretion are contraindicated with dofetilide. Lastly, ibutilide is a potassium channel blocker that also activates the inward sodium current. mixed class 3 and 1A actions. Ibutylide is the drug of choice for chemical conversion of atrial flutter, but electrical cardioversion has supplanted its use. It undergoes extensive first pass metabolism and not used orally. Initiation is also limited in patient setting due to the risk of arrhythmia. Okay, here also we have the table of the doses and the pharmacokinetics and side effects interaction between the different agents. Myodaron, we can give it oral load of 10 grams over 7 to 10 days. Then 400 milligrams for 3 weeks, then 200 milligrams per day for atrial fibrillation. Maintenance dose of 400 milligrams per day for ventricular tachycardia. Dose reduced load for bradycardia or QT prolongation. IV of 150 to 300 milligram bolus, then 1 milligram per minute infusion for 6 hours, followed by 0.5 milligram per minute thereafter. Hepatic amiodarone has hepatic half-life of 50 days. Distributes extensively in adipose tissue. Full effects take until month. Metabolized by CYP3A4, inhibits CYP-A12, CYP2C9, CYP2D6, and B glycoprotein. Non-cardiac side effects, myodarone have a lot of side effects, include pulmonary, acute hypersensitivity, pneumonitis, chronic interstitial infiltrates, hepatitis, thyroid hypothyroidism or hyperthyroidism, photosensitivity, blue-gray skin, discoloration with chronic high doses, nausea, ataxia, tremor, alopecia. It could cause sinus bradycardia. There are numerous drug interaction with amiodarone with both activity on CYP3A4 and inhibits CYP1A2 and CYP2C9 and CYP2D6 and B glycoprotein. Increases concentration of warfarin, digoxin, cyclosporine, albazolam, and carbamazepine. Statins like simvastatin, phenytoin, and quinidine increases the effect of dabigatran, but does not appear to be clinically relevant. Sotalol have a dose of 80 to 100 milligrams twice a day, maximum dose of 240 milligrams twice a day based on renal function. It is renal extend dosing interval in patient with renal disease. Non-cardiac side effect, bronchospasm. As cardiac side effect include bradycardia, torsade buoyance, no significant interactions. Regarding dopamine, oral creatine. If creatine clearance more than 60, the dose is 500 microgram twice a day. Creatine clearance between 40 to 60. The dose should be 250 micrograms twice a day. And if creatine clearance from 20 to 39, the dose should be 125 micrograms twice a day. It is renal hepatic CYP3A4. No non-cardiac side effect, and regarding the cardiac side effect include torsade buoyance, and it is contraindicated with verapamil, ketoconazole, cimetidine, megasterol, and methoprim, hydrochlorothiazide increases hydrochlorothiazide increases the dopamine levels. Must discontinue amiodarone at least 3 months before dopamine initiation. And regarding the ibutylide, it's IV, 1 milligram IV over 10 minutes, repeat after 10 minutes if necessary. It's hepatic CYP3A4. Non-cardiac side effects include nausea. Cardiac side effects include QT prolongation, torsade buoyance, and there are no significant interaction. The Dronedarone as oral, 400 milligrams twice a day with meals. It goes under renal, hepatic, and GI. Non-cardiac side effects include anorexia, nausea, and hepatotoxicity, and cardiac side effects include bradycardia. And okay, let's see. class 4. Have class 4 antiarrhythmic drugs are non-dehydropyridines, calcium channel blockers, verapamil and diltiazem. Although voltage sensitive potassium channels occur in many different tissues, the major effect of potassium channel blockers is on vascular smooth muscle and on the heart. Both drugs shows greater action on the heart than on vascular smooth muscle, but more with verapamil. In the heart, verapamil and diltiazem bind only to open depolarized voltage-sensitive channels, thus decreasing the inward current carried by calcium. These drugs are used dependent in that they prevent repolarization until the drug dissociates from the channel, resulting in decreased rate of phase 4 spontaneous depolarization. They also slow conduction in tissue that are dependent on calcium currents, such as AV and SA nodes. These agents are more effective against atrial than against ventricular arrhythmias. They are useful in treating re-entry supraventricular tachycardia and in reducing ventricular rate and atrial flutter and fibrillation. Both drugs are metabolized in the liver by CYP3A4. Dose adjustment may be needed in patients with hepatic dysfunction. Both agents are subject to many drug interactions, as they are CYP3A4 inhibitors as well as substrate and inhibitors of P-glycoprotein. Common adverse effects include bradycardia, hypotension, peripheral edema. Okay, here also the comparisons are of the doses and pharmacokinetic side effects and interaction, but I think we already went through the differences between the hydro and non-dehydropyridines, calcium channel blockers earlier in this lecture. So we have now other antiarrhythmic drugs. We have digoxin. Digoxin inhibits the action of the sacroiliacal membrane sodium potassium intibase, thereby inhibiting sodium pump. This results in greater influx of sodium and displacement of bound intracellular calcium, producing a weak inotropic effect. Digoxin also prolongs the atrioventricular node refractory period and the conduction, as well as stimulating pharyngeal function, thereby slowing down the ventricular rate. It can be used in atrial fibrillation, heart failure. Digoxin is used for the reverse the effects of digoxin in case of toxicity. Okay, now we have lastly adenosine and magnesium sulfate. Adenosine is a naturally occurring nucleoside, but at high doses, the drug decreases the conduction velocity, prolongs the refractory period, and decreases automaticity in the AV node. IV adenosine is the drug of choice for converting acute SVTs. It has low toxicity, but it causes flushing, chest pain, and hypotension. Adenosine has an extremely short duration of action, approximately 10 to 15 minutes, due to rapid uptake by erythrocytes and endothelial cells. Magnesium sulfate prolongs atrial and atrioventricular nodal refractory periods. Is indicated in the atrial and ventricular tachyarrhythmia. The cautions include myasthenia gravis, and side effects include hypotension and flushing. The dose of 5 grams magnesium sulfate IV over 10 to 15 minutes. Lastly, we have the table between the adenosine and digoxin regarding the dose. Adenosine IV 6 milligram bolus in large peripheral vein, followed by 12 milligrams after 1 to 2 minutes with cardiac monitoring if necessary. It goes under extremely short duration of action of 10 to 30 seconds due to rapid uptake by erythrocyte and endothelial cells, as we just mentioned. Non-cardiac side effects include nausea, dyspnea, flushing, hypersensitivity, cardiac include as side effects chest pain and hypertension. Digoxin dose of IV 0.25 milligram every 4 to 6 hours, up to 1 milligrams. Serum trough concentration of 1 to 2 nanogram per ml for AV AF atrial fibrillation flutter. 0.5 to 0.8 nanogram ml for systolic heart failure. And non-cardiac side effects include vomiting, loss of appetite, confusion, blurred vision, changes in color of perception. Cardiac side effects include a narrow therapeutic index causes ectopic ventricular beats, resulting in ventricular tachycardia and fibrillation. The interaction of digoxin include macrolides and cardiovascular drugs, especially amiodarone, can cause digoxin overdose through pharmacokinetic interaction, hypercalcemia, and hypokalemia, inducing drugs. Heart rate lowering drugs and drugs that prolong the QT interval or slows the cardiac conduction potentiate the cardiac adverse effects of digoxin. Plasma concentration of digoxin is reduced by carbose, cytotoxic agent, and enzyme inducers. Okay. Have lastly this table for the antiarrhythmic drugs for three different types of arrhythmia. We have sinus tachycardia, drug class, we can use class 2 or class 4, but drug of choice propranolol. We should address the underlying cause that might cause the tachycardia. In atrial fibrillation, atrial flutter, we can use class 1A, 1C, 2, 3, 4, digitalis adenosine. Drug of choice is malol, verapamil, and digoxin. Ventricular rate control is important goal for atrial fibrillation and atrial flutter. Anticoagulation is required. Paroxysmal SVTs for classes 1A, 1C, 2, 3, and 4, adenosine. Drug of choice is adenosine and esmolol. IV block atropine, we can use atropine, and atropine causes acute reversal. For ventricular tachycardia, class 1, 2, 3, drug of choice are lidocaine, procainamide, or amiodarone. Ventricular fibrillation, classes 2, 4, magnesium salts. Drug of choice are lidocaine and amiodarone. And digitalis toxicity, class 1B, magnesium salt and potassium chloride. And yeah, that was the end of my lecture. And I have a few MCQs if we are willing to see it, but if not, the time doesn't permit.
If you can just put the last slide, if you can put the last slide on just quickly, the table. Yeah, the table of antiarrhythmic.
Yes.
Yeah, this one here. Adenosine will not work for atrial fibrillation or flutter. Sometimes we use it in fast rate just to slow down the rate so we can tell what's the rhythm. So it's not used to treat the arrhythmia. Diltiazem or the beta blockers, esmolol, or actually metoprolol IV is the drug of choice. Digoxin takes time to work. For PSVT, adenosine, first choice. Second choice is verapamil, if no contraindication. And for ventricular tachycardia and ventricular fibrillation, the drug of choice now is reversed, is amiodarone, followed by lidocaine, and lastly by procainamide. One thing about atrial fibrillation with WBW, if you have a atrial fibrillation with accessory pathway, the drug of choice is IV procainamide before you give anything, because you want to slow down the conduction in the accessory pathway. If you don't do this, if you give just beta blocker or you give AV nodal blocker, the patient can go into ventricular tachycardia or ventricular fibrillation. So this is the only precaution. And digitalis toxicity, lidocaine, yes, is the one to use. You can use also phenytoin if you do not have lidocaine. And just lastly, for any patients with heart failure or coronary artery disease, the drugs of choice, just reiterating this, the drugs of choice are amiodarone or dofetilide. These are the only drugs you can use in those populations. Thank you very much. I really want to thank Faris for his comprehensive and very detailed review. He did very good job, in my opinion, and I think he deserves a present for the weekend.
الله يسعدك دكتور ناظم، مرة شكرا، والله شكرا دكتور، الله يخليك و thank you for your notes and your effort in helping me in this lecture يا دكتور ناظم يعني.
My pleasure. You did the whole work.
الله يخليك يا رب، الله يسعدك يا رب إن شاء الله. We have MCQs if you want to go through it. If not, it's okay because I just put it in just if you are willing to discuss anything or anything. That's why I put it. But if not, it's okay. I just can skip it.
It's up to you guys.
Yeah, it's up to you, really.
No, you guys. I'm just guess.
I think, Doctor, it's a praying time, and it was really a great effort. Really comprehensive review. Thank you so much. So I guess you can send it in the group, and we can just read the questions and يعني عشان نستفيد بس. Really, thank you so much.
Yeah, شكرا دكتور، الله يخليك. And these are my references. I used those references, and thank you everyone.
يعطيك العافية.
Thank you. يعطيكم العافية.
الله يسعدك دكتور ناظم، شكرا جميعا.
Thank you very much, Faris. And Dr. Nazem, thank you for joining.
My pleasure. يعطيكم العافية ونتمنى لكم التوفيق والنجاح إن شاء الله.
إن شاء الله
جميعا إن شاء الله. شكرا جزيلا.
مع السلامة.
مع السلامة.